remain.
Right. Oh. Madam, we are live.
Okay.
So, good afternoon, everyone. I invite all the doctors and faculty members on behalf of Isoparb, the live webinar with Core Connect, supported by Arush, Corona Remedies, on the breast concerns. So first of all, before starting the session, I request you all, so we should keep silence for 2 minutes for the passed away of Lata Mangeshkar. Om Shanti Shanti Shanti.
Om Shanti.
Om Shanti.
So, on behalf of Isoparb and Corona Remedies, I invite all the faculty members, Dr. Usha Sharma, Dr. Rishikesh Pai, Dr. MC Patel, Dr. Mina Saman, Dr. Sneha Buyar. There will be 2 sessions, scientific sessions, followed by a panel discussion. So before starting the session, as per the tradition, we will start the session with Ganesh Vandana.
Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
I invite all the faculty members to lighting the lamp and starting the session. So now it's my privilege to introduce masters of the ceremony. The first master is Dr. Supriya Jaiswal, who is communicator, Isoparb, and secretary of Patna Obstetric and Gynecological Society. And second master is Dr. Charu Modi, who is member of Isoparb and member of Breast Committee, FOXY. Over to you, Dr. Supriya Jaiswal.
Thank you, Mr. Abhishek. So you can stop sharing.
Yeah, please.
Good evening, one and all. Dear respected President Isoparb, Dr. Usha Sharma, Madam. Chief guest of today, Dr. Rishikesh Pai, sir. Guest of honor, Dr. MC Patel, sir. Secretary General Isoparb Dr. Mina Saman, Dr. Sneha Buriar, founder member of Vidarbha Isoparb and chairperson Study of Breast Committee FOXI. All esteemed faculty members, dear members of Isoparb all over India and all chapters. I would also like to take the privilege of taking Dr. Sadhna Gupta, Dr. Ranjana Khanna Madam, Dr. Sheila Mane Ma'am. I bring greetings from Patna, Central Team Isoparb. Today, as we all are together here to explore, learn, and share knowledge on breast concerns from the stalwarts. To start with, I would like to invite the grassroots Isoparbian, the very hard-working President Isoparb, Dr. Usha Sharma Madam. May I have her CV, please? Madam, Dr. Usha Sharma is consultant obstetrician and gynecologist at Patna, honorary consultant at Red Cross Polyclinic Patna, chairperson Safe Motherhood Committee.
Supriya, enough.
Yes, madam, you are a real Isoparbian. You're working so much. So over to you, madam, for your welcome address.
Can you all hear me?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Today's meet on breast concerns webinar gives me opportunity to welcome the stalwarts from Pan India. First of all, I extend warm welcome to the chief guest today, President-elect FOXI, Dr. Hrishikesh Pai, who has just now said he is very aggressive, but I am going to describe him as an extremely dynamic person who is going to lead FOXI and take it to new heights. I am delighted to welcome our guest of honor, Dr. M.C. Patel, who is always a guide and a savior to any one of us during our medico-legal dilemmas. Today's brilliant orator, Dr. Sheila Mane, will provide clear-cut guidelines for evaluation of breast lumps. Dr. Charulata Bape will update us on nipple discharge. Now there is a change of topic. Dr. Swati is going to deliberate, which has on fertility preservation in gynecological cancers, which has many concerns and many unanswered questions, which is going to be clarified by Dr. Swati. My sincere welcome to esteemed chairpersons, Dr. Sadhna Gupta, Dr. Ranjana Khanna, Dr. Abharani Sinha, and Dr. Mina Saman, who will add their expert comments to the topic. The person behind today's show is Dr. Sneha Buriar, who deserves special welcome and is the moderator for the panel discussion. I appreciate your efforts, Dr. Sneha, and keep up your good work. Welcome to all the learned panelists for their valuable input. I welcome the coordinators, the brilliant photographer, Supriya and Charu Modi from Patna. Finally, I welcome all the webinar attendees for sparing their valuable time on a Sunday afternoon. Happy learning, long live Isoparb.
Thank you, madam. Thank you for your wonderful words. Moving ahead, I would like to call upon the chief guest of today's webinar, Dr. Hrishikesh Pai sir. Respected sir, with due respect, I would like to thank you for your kind acceptance and for being the chief guest of today and your arrival to grace the occasion with your presence. In spite of being so busy with the Fusion 2022, a joint venture of ESHRE, IFS and SR, it is a big conference. Sir is Medical Director, Bloom IVF Group, Administrator FOXI Manyata Initiative, his President-elect FOXI, past President of ISAR and IAG. Sir has got major achievements and awarded with the esteemed fellowship and of the RCOG, London, past Secretary General, Senior Vice President, Secretary General, Treasurer, Chairman, FOXI, past President, SR IAG, awarded with 30 plus awards, including prestigious Lifetime Achievement Award for Outstanding Research in Reproductive Health by ISSRF, FOXI, Indian Medical Association, and other reputed organizations, delivered many orations and invited as faculty across the world, editor of over 16 plus books and written more than 50 chapters, editor Indian edition of British Journal of OBGYN BJOG, numerous research publications to his credits. Sir has so many laurels to his credit. Sir, with these words, I really invite you to give your address.
Thank you. Will you hire? I would like to have all of you in front of me. I would like to first and foremost thank Dr. Usha Sharma. Congratulations, madam, for being the president of Isoparb. I call them Foxy siblings. You know, they are our equals.
Yes, you are very right, and we would like to be very friendly siblings.
Yeah, of course, they are friendly. What we are from the same family. So I am also actually, many years back I had come to Patna, and I'm also a member of Isoparb. So in my Foxy year, I hope that with almost all the siblings, I have a joint conference. So I wanted to have one with Isoparb as well, one with IIG, ISAR, ISPAR, whatever, all
IMS. IMS.
So we'll plan that in the future. And I feel that the things have changed now, so we have to evolve. So I would like to first of all recognize my great colleague, Dr. MC Patel, who is a dynamic past vice president of Foxy. And there are many seniors like first of all, Mina Saman is the Secretary General of Isoparb. Congratulations. And Dr. Ranjana Khanna, our past vice president, Dr. Sheila Mani, Dr. Sadhana Gupta, all of them are past vice president, very dynamic people, very dynamic. Sneha Boer, and who's our breast committee chairman, we're going to go a long way. Abharani, of course, for so many years has been our friend. Dr. Rita Jha is there, Dr. Amita Sinha, so many of them are there in the audience. And the younger generation, Charu Bape, and of course the two important, Swasti, Dr. Swasti is there. Then the two important people who are handling this program today, Supriya Jaiswal and Charu Modi. So all of you are there, and so many of the delegates who are listening to you all. In my year as Foxy president, my theme is going to be modern technology transforms life. Because, when I was a young person in Foxy, Dr. Behram Manklesare had done modern technology saves life. So I was just thinking that because my whole life has been based on technology. So I said, I must have technology as my theme. But now maybe from the saving life, we have started evolving into transforming life. So India has become better and better, more progress is there. And now from going from mortality, let's go towards morbidity reduction rather than mortality reduction. Of course, mortality is still a challenge for us. And my good friend, Dr. Datta keeps on telling me, Rishi, I want to be in charge of maternal mortality in your year. So I said, please, Dr. Datta, you please come, but tell me what you want to do in maternal mortality. So what I'm trying to tell, my door is open by everyone. All of you want to do everything because we are a collective. See, ultimately, our goal is to serve women's health and have a good time with each other. So that is the fellowship. So coming to that, so what is the role of an organization? So there are 3 roles. I was to always say 3 roles. Then I started doing 4 roles. And just a week back, I attended a seminar in United States. And now I feel there are 6 roles of an organization. And the first role is academics, which we all do very well. I think Indians are highly academic. The second role is CSR. You have to serve the society. So our role is to serve society. People always say, what is this? They are not taking care of us doctors. They think we are businessmen. But we have become businessmen, no doubt about it. But yes, we have to try and demonstrate that we still love our people and we should serve them, because people are resentful. When people make money out of health or education, see, these are 2 very important sacrosanct things which are held very highly in the mind of Indians, the education and health. So when someone makes money out of it, people don't like it. They resent it. So you have to understand that their resentment is natural. You have to try and overcome that resentment by doing more social work and demonstrate it to them that, Baba, we are doing social work. So I believe that social work is not like, abhi retire ho raha hu, abhi main social work. No. Social work is important for our survival today. Social work is no longer a luxury. Social work and demonstrating that social work is a necessity. Because the society is becoming more disparate. The top 5% people, and we also are in that top 5%. All of us doctors are well-off people. So compared to the lower part, we are very well off, and they resent it. So we have to demonstrate that we have to go out of our way to reduce that resentment. We can't overcome that resentment. We have to reduce that resentment. So that's the second part, academic CSR. The third part is fellowship, most important. You must, at any time in the night, someone phones you, must go. You must leave everything. I remember someone, I will not tell you the name. He phoned me. I said, my daughter is at the airport in Mumbai. But she's at the old airport. I have to, but her flight is at the new airport. What can you do? I said, don't worry. I'll send my driver. I picked her up and I sent her to the new airport. But that is so our association has to have that bond. Come what may, we'll all stand together, and at whatever time of the hour, I will go and take care of my friend and colleague. Otherwise, what is the use of coming on a Zoom? But the relationship has to be more stronger and has to come from the inside. The fourth part so these were the three important things in my mind, but there are three more important things which I learned. And the fourth part is research. We need to do a lot of research. Yeah. So I want to do, at least in my year, 10 multicentric trials. So now you tell me, and we must do cluster research. 100 people should do one thing. Incidence of PI, do 100 of you come together and we will publish it as Isoparb and Doctor and Foxy. There is no problem. You must come collectively together. And because people are not interested of research papers from India on basic research. No, they don't care. They will not be cited. We have a large paper on incidence that will be cited 1,000 times. So citing is very important for us. So large observational cohort studies are important for us to publish from India. So research is important. Fifth is advocacy. Everyone has to advocate. That's what everyone does abroad. So we must identify at the MLA level, corporator level, and MP level. Every constituency will divide the country into 560 Lok Sabha constituency. Every constituency, we must have advocacy. We must catch the MP so that they all stand with each other, with us. Whenever we want to have some change in policy of the government, we want more things for the medical fraternity, you have to advocate. You can't just say, "Arey, karo." In United States, last week I attended an advocacy training program in US. How to advocate is a skill, an art in itself. So we have to learn that. We have to evolve ourselves now. And the last thing which is there is professional development. Now, that is where we are totally lacking. Professional support. Yes, some little bit of support is there. Social security scheme is there. Medical legal covers we have put in. But we don't have a medical defense union. Every year, all of us take 10,000 rupees and give it to the insurance company. Imagine 38,000 into 10,000 is how much? And how many cases must we have against us? Maybe 100, 200. So we must make a corpus fund and put the money in that corpus. So till the time we have our corpus fund, which is large, and for that, my friends from Gujarat, we will take help of. They already have a medical defense union. So we will start the union. And we must say, no, we will all pay 10,000 into the corpus fund. And we will take premium cover for 4 years. By the time the fund will become, God knows how many crores, I don't know. Then we don't need to pay the premium. So we have to now evolve towards that solution. And the collectivism for practice development is very important. Most of us are now, rather than doing practice, we are doing marketing of the practice. So the federations have to create a platform where all of us get 1,000 patients a year. Let us have a Ram Rajya. India has got billions of people. So each of our, because that is very important. Practice is important, for your existence. See, all of this we do, we go out, we have enjoyment, fun. But for that, we need to have a basic existence. So that existence, we are not helping each other. So these are the 6 platforms which are important. And I would like to end my talk. Thank you very much for this invitation. And let us see. See, it's a change. I will come and go, but I want to give an impact, and continuity is very important. So continuity is very strategic planning. In the IFFS I am there. They had a meeting of strategic planning. You know how many times they met? For 3 years they met. strategic planning. Wow, how the organization will be 10 years down the line, how the organization should be, what should be the strategy. It's called strategic planning. So we need a strategic planning meeting of the Federation. We have to all take all of them together and to one Goa or something for 5 days, brainstorm, think of how we are going to promote the Federation and of course the sibling organization, our Isoparb, they are all our members only. So this is all very important. Anyway, thank you very much for all this and your love and affection. I love the North, but Bihar, UP, there's a heart of India. It is the passion, the culture, the history, everything is in that belt. And you are so lucky to be in that belt. Thank you.
Thank you so much, sir, for sharing your thoughts and insights with us. Really, these points are really worth to ponder. Thank you once again. Now we move on, and I would like to invite and welcome our guest of honor of today's startlingly beautiful evening, none other than Dr. M.C. Patel, sir. We all know sir has done tremendous work in the field of medical legal issues as far as gynecologists and obstetricians are concerned all over the world. Just to briefly introduce sir, sir is a consultant obstetrics and gynecology and a medical legal expert. He was the Vice President FOXI 2018, Organizing Secretary of AICOG 2017, and sir has been the Chairperson of Ethics and Medical Legal Committee FOXI in the year 2011 to 13. He was the Honorary Joint Secretary and State Organization of Gynecologists and Obstetricians at Gujarat, and was the Honorary Member National Inspection and Monitoring Committee PCPNDT Act, Government of India. Sir has been honorary surgeon in various societies like IMA, Red Cross, eye banks, and has collected more than 1,000 eye pairs. With these words, I invite MC Patel, sir, to give his welcome address us, sir. Over to you.
Thank you, Dr. Charu, for kind words and introduction. Thank you very much, and let me congratulate first Isoparb and President Dr. Usha Sharma Madam, Dr. Mina Saman Secretary, and today's program designer rather, Dr. Sneha Buyar, who has personally invited me as a guest of honor to share my views and bless this webinar. So with Dr. Rishikesh Pai, chief guest of today's function, and in whole of frame, only Rishikesh for male doctors. Otherwise, all the Matru Shakti is there in the frame. But anyway, it's a very important topic we are going to discuss today as far as breast concerns are concerned. And all the learned speaker or faculties rather, Dr. Sila Mane Madam, Dr. Charu Bapai, Dr. Swasti, and very important panel to be moderated by Dr. Sneha Buyar, Chairperson, Examination of Female Breast Committee, FOXI. And I have seen her working since long as far as this committee is concerned. And under her able leadership and Charu Bapai as a national coordinator, they are working a very fantastic work as far as this breast committee is concerned. So congratulations for that also. And all the learned chairpersons, Sadhna Gupta, Rinna Khanna Madam, Abarani Sinha Madam, and of course Mina Saman, and all the learned panelists, Dr. Rita Kumari Jha, Dr. Amita Sinha, Dr. Charu Modi, Dr. Manisha Gate, Dr. Rasmi Kahar, and two lovely coordinators, Dr. Supriya Jaiswal and Dr. Charu Modi. As far as this breast concern are concerned, in our day-to-day practice, from simple premenstrual syndrome to mastitis or breast abscess or lump, whether it is benign or whether it is malignant. But as far as malignancy part is concerned, we are directly concerned as an obstetrician or so, and government, central government is also worried for the same, because as far as oncogenic deaths are concerned, with cervical cancer, breast carcinoma is sharing highest number of deaths. So it is a matter of consent only. And naturally, we know three parts, as Rishi said, some pillars for Foxy activity. But if I go with this breast carcinoma, then again three pillars: prevention, early detection, and meticulous management in any given stage will be the prime concern. And again, indemnity part, Rishi has nicely touched, and he mentioned about Gujarat. So in Gujarat, we run very important scheme, that is professional protection scheme, which is run by Indian Medical Association Gujarat State Branch. And I had been director for that scheme also in past. So we have enough fund, I mean it, enough fund. And we have our own office, not less than corporate house. And we have stopped collecting annual premium. We have just collected this year only 500 rupees as an admission fee. And still we cover compensation of rupees 1 crore per year if at all any member of our scheme loses the case. And as far as any case, medical legal case is concerned against any member of our scheme, in Gujarat, we have panel of advocates in each and every city of Gujarat. So whosoever member faces any litigation or notice, he will simply inform office. Office will give list of advocate. He can choose any advocate of his or her choice, and then that particular advocate is instructed from the office to assist our Foxian, Gujarat's colleague, and we fight for the case. And usually we win the case, and in very few cases we have to pay for compensation. So we have enough fund that way. So if at all Foxy thinks in that way, I think this is great thing to be put into action here. Of course, we have indemnity scheme on Foxy level, but rightly said by Rishi, whatever amount we collect as a fees, annual fees or indemnity coverage fees, lots of money we give to insurance company. Let us have our own scheme with Foxy. And of course, very rightly said by Rishikesh, Gujarat will be helping in that way. We have our own constitution, how this scheme can be run and how this scheme can be very fruitful to our Foxian friends. So it is nice move forward if at all Rishi puts in his tenure as a president of Foxy. And one more thing, as a medical legal person, naturally I will mention one very important case as far as indemnity part is concerned related to breast. Of course, this case was decided in foreign country. She was a model and she was diagnosed by FNAC or some investigation that she had carcinoma breast. So radical mastectomy was advised, breast was removed, but unlucky on part of that doctor, histopathological report was very normal and there was no malignancy in that breast. And she showed a very huge amount because she was model, and she, her argument that the breast was my important organ as far as my model career is concerned, and huge compensation was awarded in favor of that model. So in this type of situation, we are in a very big trouble. But if we are supported with indemnity scheme or so, then only we can be saved. So be careful in this type of situation also. So congratulating team Isoparb again, and my blessings are always there for any webinar to be successful. And thank you very much for inviting me and sharing my views about the subject. Thank you very much.
Thank you so much, sir, for sharing this information about various schemes with us. And we really look forward to its implementation in near future in Foxy also. Thank you so much again, once again, sir. Now I invite a very soft-spoken, humble, yet hardcore Isoparbian, none other than Dr. Mina Saman, who is the Secretary General Isoparb. And to say a few words about her, let me introduce her. She is a senior consultant, head of the department OB-GYN, Kurji Holy Family Hospital, Patna. And at present, she is the chairperson of Clinical Research Committee of Foxy.
Thank you,
She's
Charu.
also...
Thank you, Charu. Okay.
I just said she's so humble and it proves she's proving it. Over to you, Dr. Mina Saman. Madam, please.
Respected Chief Guest, Dr. Rishikesh Pai sir, our President, Dr. Usha Sharma Madam, Guest of Honor, Dr. MC Patel sir, Dr. Sneha Bhuyar, Dr. Ranjana Khanna, Dr. Sadhna Gupta ma'am, Dr. Sheila Mane, all the dignitaries here, all the audience who've joined in here. Good evening to one and all, my namaskar. And today is and the audience, welcome to this meeting. Today is a special day, I would say, because we are talking of so many new things, so many futuristic plans, including our next maybe a venture together with Dr. Rishi's tenure. We'll be looking at many positive things. So thank you. And I was not sure that I have to speak here at this moment. But thank you, Dr. Supriya, Dr. Charu, for calling me once again, because what is coming in near future for our society is an annual conference, which is going to be in the month of May, 6th, 7th, and 8th. Please block your dates. Please come in good numbers. Make it a good, grand success. I think the holy city of Varanasi is waiting for us all. And then a special message that's been sent to me by our editor, Dr. Hiralal Kunar, for the Journal of Isoparb, that please give in good articles for the journal. And now it's catching up, because last year there was some delay in publishing because of the COVID and other things. So it's all taken care of. And so now the backlog is all coming back. So with those words, and wishing all the success for this very focused, meeting on breast, a reproductive organ. Thank you, Sneha, for bringing it back in the domain of the gynecologists. So today we're going to concentrate here. It's a very important reproductive organ, I would say. And so with that, let's have a very fantastic evening and happy learning. Thank you.
Thank you, Dr. Mina, for your wonderful words. Now let us hear from Dr. Sneha, who's the main force behind this conference, behind this webinar. She is the convener of this program. She is the founder member of Vidarbha Isoparb and chairperson.
Yeah, thank you so much, Supriya. I would like to skip this introductory part. I would go straight away.
Kindly say a few words.
Yeah. Respected President Isoparb, Madam Usha Sharma, today's chief guest, Dr. Rishikesh Pai, who is the President-elect FOXY, our guest of honor and committee advisor, Dr. MC Patel, my national coordinator, Dr. Charu Bapai, all the respected faculties, senior FOXians here, Dr. Sheila Mane, Dr. Sadhna Gupta, Dr. Ranjana Khanna, Dr. Abharani Agency, and so many other, and all the faculties and delegates. A very warm welcome to all of you. I just take this opportunity to thank all of you to join this program. I always believe gratitude is the best attitude, and whenever I have this opportunity, I don't want to miss thanking anybody. Rather, I just want to share a few thoughts on this committee work. Basically, I'm a high-risk obstetrician, practices last 29 years, but I always want to be the chairperson for Medical Disorders Committee. But some of the advisors, as they suggested, Sneha, if you take any committee, we are sure that you're going to do very well. And that's the reason I just thought of this committee, and with all your help and active participation, we could achieve this success. Our committee is working on 3 aspects mainly: breastfeeding promotion, tackling benign breast diseases, and awareness, screening, and early detection of breast cancer. And for this, we are working on a 3-tier basis. We are sensitizing the FOXians. We are updating the knowledge regarding this, as all of you agree to me, that as postgraduate, we were not having this as part of the curriculum. And so right from anatomy, physiology, everything we are, updating the knowledge by organizing such continued medical education sessions. We are training the paramedics and we are making awareness in the general public. We are organizing screening sessions and trying to, reduce the incidence of breast cancer. It is not preventable totally, but yes, we are trying to reduce the morbidity and the deaths associated. As obstetrician, I used to always feel that we are saving these women from these obstetric catastrophes, but we are losing them to these two deadly cancers, breast cancer and cervical cancer. And that is how I thought of taking up this mission. And we are working on this aspect since last 29 years, organizing so many social programs and awareness camps and screening camps. So thanks to all of you for joining this program, and thank you for all your blessings. Thank you so much. Special thanks to Rishikesh sir, MC Patel sir for joining the program. Thank you, sir.
Thank you. If you allow me, I'll take your leave.
Sir, thank you so much.
Thank you.
Thank you, sir. Thank you, sir. Thank you. So thank you, madam. Thank you, Sneha, madam. So before we start the first session, so may I maybe have the CV of the first session chairpersons. I would like to tell Dr. MC Patel, sir. I believe certain people cross your life as guardian angels, and some connections can't be explained off in words alone. It's a soul thing we feel. We all Foxians, sir, we are all indebted by you because, sir, you are the one who really helps in all the medical legal aspects and all the laws. You are always there to help all of us, sir. Thank you very much.
Thank you. Thank you.
Thank you, sir. And thank you for being here, sir. So we start with the first session. To chair the session, we have Dr. Sadhana Gupta, madam. She's Foxy representative to SAFOG, ICOG Governing Council member, awarded for Best ICOG Governing Council member. Then she is corresponding editor of Jogi, then Vice President Foxy, Chairperson Foxy, Safe Motherhood Committee, Dr. Mehru. She has been recipient of Dr. Mehru Dara Hansotia Award for Best Committee Chairperson of Foxy, Foxy representative to WHO and UNFA workshop. Then Madam has got her academic honors are too many. She has been the Chancellor of Chancellor Medal for the Best MBBS Student, recipient of 9 gold medals in MBBS, Dr. Naval Kishore Gold Medal for Best Postgraduate Student, thrice Korean Award for Best Scientific Research Paper, 4 times Best Research Paper Award in AICOG. Then Madam has many social and organizational awards like Foxy N.A. Pandit and Dr. Mrs. Shailaja and Pandit Award, Economic Times Awards, Padma Bhushan Award, Duru Shah Award for Distinguished Community Service Award, Dr. Savita Rastogi Award for Best Director of UP IMA. Conferences and workshops, she has organized many. Then her contributions in many books, chapters, publications, present designation, she is Director and Senior Consultant OBGYN, Jyoti Hospital, Jeevan Jyoti Hospital and Medical Research Committee. And she is founder, Trustee Jeevan Jyoti Trust, Gorakhpur. With these words, Madam, I request you to chair the session.
Thank you.
The next chairperson is Dr. Ranjana Khanna, madam. She is Senior Consultant and Director, Ranjana Hospital, Prayagraj, National Vice President, Foxy. She had been in 2017 ICOG Governing Council member. At present, President AOGS, that is Allahabad, Honorary Secretary AOGS, Treasurer AOGS, Organizing Chairperson, National Foxy Conference, BOH, the Trilogy, Delhi. In 2017, she had been the Organizing Secretary of National Foxy Conference at Allahabad, Faculty at various national and international conferences, national awards. She had received many like Foxy Smithy, Milan Award and Save the Girl Child, AICOG 2013, and DK Tank, Foxy Dr. DK Tank Reproductive Health Promotion Trophy by AICOG 2015. Felicitations, she had many, and she had Public Awareness Committee and Family Welfare Committee, Safe Motherhood Committee, Oncology, and many Midlife Committee. Madam has got many accolades to her credit. She has been authored many articles and chapters in various books. Overall, she's a very lively person, very friendly and very nice. Dr. Sadhna Madam and Dr. Anjana Madam, over to you people for the scientific session, first session. May I request Dr. Sadhna Madam to kindly introduce Dr. Sheila Mane Ma'am.
Thank you, Supriya. And with all regards to Chief Guest and Guest of Honor, actually it is a moment of a pleasure and a pride to introduce Dr. Sheila Mane, who has been an integral part of my journey in Foxy. And she is so close to my heart that it is difficult for me to introduce her like a only formal CV. I took baton from her as a chair Safe Motherhood Committee, and we consider ourselves as a twin face for safe motherhood. And I imbibe simplicity, focused, and the dedication and the persistent effort in what we believe. So I owe a lot to Dr. Sheila Mane in my life, in my Foxy journey, and we look forward to work together for many, many years with our combined and the same thought process and the action process, which are simple but very tough. Yes. So Dr. Sheila, a little bit about a formal introduction. She has been AICOG Organizing Secretary 2019, past Foxy Vice President, Chairperson Safe Motherhood Committee. She is considered PPH Lady, ICOG Governing Council member. She has many, many awards, Best Committee Award, Best Society Award, President Trophy as a BSOG Secretary and DK Trent Trophy. So she is a very, very known person. It is a pleasure to introduce her. And a little bit about subject. We are really eager to listen to you because what we say, South Asia has got a different issue in the breast lump and the breast cancer. And we have to have a little different, and I may be quite different strategy from the Western world, because we have a much more to do in the primary prevention, secondary prevention, and tertiary prevention. So Dr. Sheila Mane, we are eager to listen to you, and stage is all yours.
Thank you. Thank you, Dr. Sadhna, for those kind words. I think I'm so happy because all of us are really have passion towards not only safe motherhood, but I think for women's health. And that is why we all are here today. And thank you, Dr. Sadhna, as well as President Isoparb, Dr. Usha Sharma, for giving me this opportunity to be here. Okay. And the topic, I think, is very apt. Sorry, I think I have to go back. I'll stop share. Before that, I just want to say that Dr. Sneha and Isoparb Society, the theme for this year International World Cancer Day, that is from 22 to 24, is Close the Care Gap. And I think by doing this program, definitely I think we are going to serve this purpose. Now the initiative is meant to motivate reform and inspire action even after the actual day has passed. And even though we are on 6th February, ideally, it is very apt for us to talk about this because we have to close the care gap. That is the theme. And I think I must thank for giving me this opportunity to talk on this topic, which is really apt because we are going to do awareness programs and everything this whole week. So thank you once again for the opportunity. Can you see my screen? Is it visible?
It's coming. It's not coming.
Yeah,
yes.
Just.
Thank you.
Yes.
I'll just make a slideshow.
Yes.
Yeah.
Now perfect. Yes.
So approach to breast lump and lesion. Now incidence, the complaints of breast lumps or lumpiness are very common. And all of us, we know that we basically the obstetrician and gynecologist are like a family physician to our patients. So the first person they approach is we, and very important for us to know that how do we evaluate that. And the incidence is ranging for 40% to 70% in women seeking advice. Now, breast lump raises the fear of breast cancer in any woman. Majority are benign, but this does not negate the need for evaluation and for any palpable breast lesion. Now, all of us are aware of this anatomy, but it is always better to know so that we know that how we tackle this. The burden of the disease among Indian women, breast cancer is the commonest cancer in Indian women overall. And in 2018, there were about 1,62,468 new cases and 87,000 around deaths were reported for breast cancer in India. See, as we are approaching towards the sustainable development goals for maternal mortality, we also have to concentrate on these causes, that is breast cancer and cervical cancer. Now, the risk factors you cannot change, which are non-modifiable, are the gender. Women more likely to develop, maybe due to more exposure to hormones which promote the breast cell growth, such as estrogen and progesterone. Yes, age. Risk of breast cancer increases with age. And there was a study in North India reported that the average age of the patient at presentation was between 45 to 50 years. Family history is very important. Risk of breast cancer increases if mother, sister, or daughter was diagnosed with breast cancer, particularly at a young age. But I think even the paternal history is also very important. We should also ask whether there was somebody suffering, like even a father, sister, or father, mother also. All of us, we know in IMS now we have a Gale model to assess the risk of breast cancer. Risk also increases if your father or brother had breast cancer, if they had breast cancer. However, the majority of people with breast cancer have no family history. Genetic factors, most common known gene mutations observed in people with breast cancer are in the BRCA1 and BRCA2 genes. Having these mutated genes does not necessarily mean that women will get breast cancer. Menstrual history, very important. First period at a younger age increases the risk. Likewise, attaining menopause at an older age, like delayed menopause, increases the risk. Past history of breast cancer have an increased risk of developing cancer in the other breast. The risk factors you can modify. That is very important now, because when we are spreading awareness. Obesity, being obese increases the risk. Pregnancy, women who have never been pregnant have a greater risk of breast cancer. Also, giving birth to a child after the age of 35 may again increase the risk compared to women who gave birth earlier. And lack of shorter duration of lactation again increases the risk of breast cancer. Drinking excessive alcohol increases the risk. If the patient is on MHT, I mean, yes, definitely when it is given, we have to be careful. Radiation exposure, moderate to high doses of exposure to ionizing radiation exposure or receiving radiation treatment to chest area as a child or young adult again increases the risk. So how can it be prevented? By changing the lifestyle related risk factors. Maintaining ideal body weight, exercise, smoking should be, I think they have to quit smoking and excessive alcohol consumption, lactation, breastfeeding the baby, and avoid unnecessary radiation exposure. Now, whenever when should you consult a doctor? That is always, I mean, we have to spread the awareness amongst the patient. The breast cancer signs, the most common symptom of breast cancer is a new mass or a lump in the breast. A hard mass, it is more likely to be cancerous. Any change in the breast or nipple appearance, unexplained change in shape or size of the breast, unexplained shrinkage of the breast, unexplained swelling of the breast, especially on one side only, and recent unevenness of the breast. It is normal for women to have one breast slightly smaller than the other. But if this asymmetry is a recent one, then consult the doctor. Dimpling anywhere, sunken or inverted nipple. I think this will be dealt by another speaker. Women can check for these signs of breast cancer by examining her own breast every month. And if anything abnormal, they should consult a doctor and clinically examine. Now, these tests are for early detection, that is clinical breast examination. Yes, clinical breast examination is recommended for all women once a year after 30 years of age. So CBE is an examination of breast by a health professional such as a doctor, a nurse, or a medical social worker. The health professional will first look carefully breast for abnormalities, changes in the nipple, skin size or shape of the breast, and then we'll have to palpate it with the fingers and feel and palpate the breast for the presence of any lumps. Okay. Also examine the area under both the arms for any swelling or lymph nodes. Now coming to the self-examination. It is suggested an option for a woman above the age of 20 years to look for early signs of breast cancer. And there are 5 steps of breast self-examination. I think I will try to skip this because all of us are aware because it's more important. So we know this, we should have the charts with us. So whenever the patient comes to us, I think every patient, whether she is pregnant or not pregnant, in our clinic, we should be giving these charts to them of the self-breast examination. And we should again give them the knowledge about that. Now, how can it be diagnosed? Breast self-examination can be done at the comfort of your own home. We have to tell them. Those who are menstruating every month should be done 7 days or within 1 week after the menses have stopped, and post-menopausal on a fine day every month. So if there is a breast lump, it could be self-detected, it could be screen detected, or it could be clinician detected. Now coming to the differential diagnosis, it could be malignant, could be a breast abscess, could be a fibrocystic change, which is very common, you know, and now as the awareness is spreading, many people come with the pain and mastitis. Mastalgia particularly. So lumpiness, thickening and swelling of often associated with woman's period. Fibroadenoma, the solid, round, rubbery lump that moves under skin when touched, occurring most in young women. Infections, the breast will likely be red, warm, tender and lumpy, and trauma. Could be due to a blow to the breast or a bruise can cause a lump. That can cause traumatic fat necrosis. So our goals are we have to exclude malignancy, provide diagnosis and address the presenting symptom. Prove all lumps to be benign before deciding to observe them. I think Dr. MC Patel sir gave us an example also. So what are the symptoms? Different people have different symptoms of breast cancer. Some people do not have any signs or symptoms at all. Some warning signs are new lump, I think thickening, irritation or dimpling, which I already spoke about, redness or flaky skin, pulling in of the nipple or pain in the nipple area, nipple discharge other than breast milk, including blood, any change in the size and shape, and pain in the area of any area of the breast. So confirming the presence of a mass, the first crucial step is to determine whether a discrete mass is indeed present. The discrete masses are 3-dimensional. So measurable means there are definite borders, distinct from surrounding tissues, and generally asymmetrical when compared with other breasts. So history, again, detailed obstetric and menstrual history, whether the patient is on MHT, either estrogen or progesterone, family history, history of breast trauma, history of breast biopsy or disease earlier, and systemic assessment. For example, whether there is any neurologic, cardiac, or integument or vascular, etc., any other comorbidities. Factors that will help in elucidating the possible cause, the mode of presentation, age of the patient. In women less than 30 years, a single lump is most commonly fibroadenoma. Younger the woman, the greater the probability that a breast lump will be benign. The chance that a breast mass in a woman under 25 years of age is cancerous falls between 1 in 229 to 1 in 700. With increasing age, more than 40 benign breast problems are less frequent. Clinical abnormalities should be regarded as possible cancers until documented as benign. And by the age of 70, more than 3/4 of the masses are malignant. So clinical breast examination is a digital palpation, which is effective in detecting masses, assist in determining whether the mass is possibly benign or malignant, and can detect up to 44% of cancers, of which up to 29% would have been missed by mammography. So we know mammography is not possible for everybody. Clinical breast examination holds very good. Physical examination, yes, exposure from breast up, examine supine and sitting systematically, evidence, document with figures, which is very important. So physical examination, shape and size, notice asymmetry, look at the nipple, whether inversion, retraction, destruction, again skin, retraction, tethering, edema, inflammation, ulceration, or there are satellite nodules and character of lump. Then lymphadenopathy, we have to palpate the axilla, the supraclavicular area, as well as the intraclavicular, because there are lymph nodes in the different areas, supraclavicular, infraclavicular, lateral axillary group, central group, subscapular, and the pectoral group. So a search for axillary nodes, okay, and supraclavicular nodes. Documentation is very important, so we should have a form like this where we have taken all the details and where the history is there, examination finding, examination of the nipple, the skin, everything is written here in this chart, and which should be noted. And again, whenever we are examining, this should be there so that next time the patient comes, we have all the details. So documentation is again very important. The breast can be divided like a clock, and then we can write where we have felt the lead. And describe all clinical examination findings, including normal and abdominal, indicating size, shape, mobility, and location of palpable finding. Then the plan and the referral also. So normal, benign, fibrocytic rescreen in 1 to 2 years, probably benign, repeat examination in 3 to 6 months, mass or other findings, again, immediate testing. Okay, so this should be done. So documentation, very, very important. We can have even a diagrams like this. Infections such as mastitis are characterized by signs of inflammation. Similar symptoms may be present in patients with inflammatory breast cancer. Okay, recently I had a patient who is undergone a core biopsy, but it has come as a granulomatous breast disease. It is not tuberculosis, which is ruled out, but the mass exactly looks like a breast cancer because there is inflammation. It is granulomatous. Caution should prevail when assessing patients with suspected breast infections. So if we look at this is a sub the breast post addition from Lipinco. Breast lump, physical examination, no abnormality, reassurance. Thickening, not cornering, re-evaluate in 2 to 3 months. Clinically benign, yes, imaging. Clinically suspicion, imaging and biopsy. Now, palpable lesions are always imaged before a biopsy is done. Imaging, mammography is the standard of care for clinical abnormality in more than 30 years. Should be done even if malignancy is proven. Always bilateral, at least 2 views plus additional views, dedicated radiologists. Again, Birad's grading has to be done, and you can also have a hand lens. Now, mammography indications, palpable mass, thickening in a lady over the age of 30 years. If there are skin changes or inflammatory changes, axillary lymphadenopathy with normal clinical breast examination, newly diagnosed breast cancer, symptomatic males, and screening. Now, features, signs of malignancy on mammography are shape, irregular or nodular, margins, whether they are spiculated, indistinct, or micronodular. Calcifications, clustered, pleomorphic, linear or fine linear branching, architectural distortion, and skin thickening. So this is the description of Birad's category. 0 needs more information. Likelihood of malignancy is very less, 2 to 10%. Recommendation, further imaging studies. 1 is normal, 0.5 to 1%. Routine screening mammography. 2, routine screening mammography, it is benign. 3, probably benign, short-term follow-up because the incidence is 0.3 to 1.8. Highly suspicious, very high. We have to go for biopsy. Malignant, suspicion or looks like malignancy, biopsy, and known cancer, we will have to treat her accordingly. So these are the images, that is Birad's 1, Birad's 2, Birad's 3, and Birad's 4. This is again a digital zoom mammographic projection images show from left to right, round, oval, and irregular masses. An irregular mass has a high probability of malignancy. Diagnostic mammography sensitivity is 90%, specificity is 88%. Digital mammography advantages are better image quality, fewer artifacts, fewer patient recalls, and telemammography. So now we know that telemedicine is also there. So even telemammography, a malignancy easily missed with conventional 2D mammography was clearly seen with hologic 3D mammography. Now, factors affecting sensitivity, age and breast density.
Ma'am, sorry to interrupt. I am from the technical team. Actually, you have 2 minutes left as per the schedule.
Okay, fine. I may take 2-3 more minutes. Okay.
Thank you, ma'am.
Please allow that. So age and breast density, hormone therapy, biologic subtype, lobular carcinomas, and all other factors, patient factors, silent areas, high BMI. Our patients have increased density and presence of implants impairs the sensitivity. Coming to ultrasound, which is the commonest investigation, we advise even whenever we have a young patient, because straight away we do not go for mammography. So can characterize masses, distinguish from lumpiness, MRI, detected mammo occult lesions we can have a second look ultrasound. Best imaging modality in women with less than 30, detects multicentricity, detects LNS, that is lymph nodes also, guided procedures, and sonologist should be meticulous and skillful. USG, pure and intensely hypoechoic texture of benign tumors, elliptical shape it could be, and wider than tall, 3 or fewer lobulations, complete thin capsule. So these are the USG features. Again, you may have hard findings, intermediate or soft, okay, depending on the involvement, either speculations, thick halo, angular margins, or acoustic shadowing, hyperechoic, microlobulation, taller than wide, and duct extension, branching pattern, and calcification. So we commonly see these type of cyst. Patient might come with pain also, or fibroadenoma. Breast cancer, the picture is totally different with irregular margins. So USG is a valuable tool, widely available, quick to perform, non-invasive, and it accurately differentiates a solid from a cystic one. And specificity in detecting cystic lesions is almost 98%, and more than 2 millimeter cyst also can be detected. MRI is equivocal to mammogram, USG or CBE. Axillary node malignancy with unknown primary site, occult, can be detected, and staging of the disease and finding multiple. So pathology, we know we can do either FNSC, core biopsy, true cut they prefer now, vacuum assisted, incisional or excisional. Okay, this is fine needle. Specific advantages, again, immediate evaluation, useful in case of lesions at site inaccessible or unsafe for core needle, and therapeutic in the management of palpable cystic masses. Core biopsy, again, better accuracy, more tissue, obviates the drawback of FNSC, current standard of care. Procedures, most of the time, even the lab people are trained now and they do it in lab, either core or true core biopsy. Core needle biopsy also can be done. Specificity is 85 to 100, sensitivity 95. Multiple core improves the sensitivity. These are the vacuum assisted, again, incision and excision biopsy also can be done. Okay, so advantages, we know that FNAC we discussed already. If difficult for the core biopsy or the true cut, then we can go for that. Okay, so these are the types. So coming to this, joining the pieces, what is important today is the triple test. That is clinical examination, radiology, and pathology. So currently the gold standard for the assessment of all patients presenting with symptomatic breast disease is this, and with solid masses. So when adequately performed with the 3 components, diagnostic accuracy of the triple assessment approaches is 100%. More than 95% of palpable malignant breast lesions can be diagnosed in this way. For benign disease, most large series reports a false negative rate of 0.1 to 0.7%, and false positivity rate is around 0.4. Okay, so mammography, again, there is a flow chart how we should go. Visualized, benign, only ultrasound. Not visualized, also ultrasound. Visualized and suspicious core biopsy. Again, not visualized, FNSC or core biopsy. Visualized, if it could be a simple cyst or a complex cyst or a solid mass, we have to go for core biopsy. On core biopsy, adequate sample, treat appropriately. Atypia, inadequate or discordant, again excisional biopsy or core if FNA was inadequate. So there could be discrepancy between FNSC and clinical examination. So performing all biopsies under image guidance, either sonographic or stereotactic, will be helpful, and that reduces the frequency of false negative results. Okay, so age group wise distribution, less than 25 fibroadenomas, up to 25 to 35 also fibroadenoma, 35 to 55 fibroadenomas, phyllodes tumor, you get large ones. Okay, more than 55 phyllodes tumor. Again, ill-defined, we know it is fibrocystic, sclerosing adenosis, even elderly is also fibrocystic changes. More than 55 years, fibrocystic disease is uncommon. Firm lump, plus or minus tethering, in age group between 25 to 30, we'll have to rule out carcinoma. Further age advances carcinoma. Nipple discharge, again, I think the speaker will have more attention to that and we'll speak about that. So management, cyst aspirated to dryness, area palpated for a residual mass. If the fluid is not bloody, the mass disappears. And fluid is not submitted for cytological examination because of low likelihood of cancer. Finding of atypical cells in the cyst fluid cytology is not uncommon and indicates the need for a biopsy. But I think once we aspirate, better we send. Pointing to pathological cause, a bloody cyst, non-resolution of the palpable abnormally after fluid aspiration that recurs again between 4 to 6 weeks. This can either be due to a benign lesion or a malignancy. Irrespective of this, these cases warrant surgical excision. Solid, the management of a solid mass depends on the degree of clinical suspicion and the age of the patient. So, if a benign lesion is diagnosed after a triple assessment, option includes surgical excision or follow-up. It is not necessary to excise all benign solid breast masses because patients do come to us with very small fibroadenomas. In the event of a conservative approach being preferred, there must be a definitive follow-up plan which is important to facilitate the early detection of a missed cancer. Patient is examined every 3 to 4 months for 1 year to ensure stability of the mass. Mass is measured at each visit and compared with the size at the initial presentation. This approach should only be undertaken by a physician experienced in the evaluation of the breast masses. Okay, so if the breast lump is found to be cancerous, multidisciplinary treatment. Okay, 5 standard breast cancer treatment options: surgery, radiation, systemic, hormone therapy, chemotherapy, and targeted therapy. So in a nutshell, the palpable mass in a woman's breast represents a potentially serious lesion, should never be dismissed. Imaging should be performed before biopsy of a solid mass. Younger women, ultrasound is preferred over mammogram. MRI is of little benefit in the workup of a palpable breast mass. So triple test is the standard of care for evaluation of a benign and malignant solid lesions. Cyst can be aspirated and for confirmation of their benign nature, and cytology can be confirmed. Pregnant and young patient pose a diagnostic challenge because of breast density, and ultrasound is the modality. I must say that we must palpate even the pregnant patient when they come the breast. I had 2 cases of pregnancy-associated breast cancer. Low threshold for prompt evaluation over observation should be maintained in a gravid patient. So the next objective could be distinguish simple cysts from solid lesions. Simple cysts are aspirated to dryness and require no further treatment if they do not recur. Pathological cysts require excision. Solid lesion requires a firm diagnosis and a histological examination. Benign lesion may be managed expectantly, provide regular follow-up. Malignant solid lesions are referred to a multidisciplinary team. So dear friends, take-home messages: become breast lump aware and make others also aware. Do monthly self-breast examination, get regular screening done. Modify lifestyle if indicated. Approach a doctor immediately if something doubtful palpated on breast. Participate in diagnostic procedures immediately if required. And triple test is the mainstay of diagnosis. So this message we should be given to every patient who visits us. Thank you very much for patient hearing.
Thank you, madam. Now may I request Dr. Anjana Khanna, madam, to give the closing remarks.
Firstly, I would like to thank our National Isoparb Society and especially President Ma'am Dr. Usha Sharma, Secretary General Dr. Mina Saman, and the communicator Supriya Jaiswal. Thank you all so much for the invite, and I would like to thank Dr. Sneha Bhuar, who is the chairperson of the breast committee. Dr. Sheila, I would like to say congratulate you for this wonderfully complete presentation. It was so well chalked out, and it's such a huge topic actually. So that was, I think, the maximum you could muster inside. But I would like to say one thing, that nowadays we are having a lot of incidents of fibroadenomas in adolescents. Yes. And I remember as a house surgeon, when I was as an intern, when my posting was in surgery department, the first thing I was told was about the breast mouse or the fibroadenoma. So that's how we got introduced to that topic. And now we see in our practice that so many patients are coming with fibroadenoma, and then we have to get an ultrasound done. But here we've got a very nice center, and they give very complete reports also, nice machines. So BIRAD staging they will do, and with ultrasound also, and they will tell us. So that puts the patient at ease. And another thing which is very common, and if it is associated with menstrual cycle, then we can always think in terms of fibrocystic disease, because fibroadenosis, because whenever we palpate the breast, we have that granular feel, the typical granular feel. It is not a specific lump which is there. So in those cases, I have seen some response with the evening primrose oil, and also with ormeloxifene, 30 milligrams given alternate day. So that is the only treatment we have at hand, except for counseling the patient and reassuring the patient. As it is fibroadenoma, the incidence is 2.2% in adolescents, and 70% basically of all the breast lumps in that age are fibroadenomas only. And I don't know what is your experience of ormeloxifene and evening primrose oil, but that is what I am regularly.
Like evening primrose oil, yes, definitely.
Yes,
it gives them a lot of relief, because fibroadenosis, otherwise there is
fibroadenosis is very well treated with these two things.
Most of the time by surgeon, they usually start them on vitamin E, which is used to be the earlier standard. But now
another thing is, and another thing is that sometimes we are caught unawares. There was this very young girl, 28 years. She came to me. She said, I have got this diffuse lump, and she hadn't felt anything. Her mother was cooking something. She went, and the elbow of her mother touched her breast. And then she touched her breast and realized there's something amiss. So she came to me. I got suspicious. I said, but her age is very young. But I sent her to the department, and when they did an ultrasound, immediately they said it is ductal carcinoma. So she went ahead and she got treated. She's still alive now because of that early detection. So we have to keep our minds very sharp. And I think Dr. Sheila has given a great insight into the breast cancer incidence and the management and the detection. But we must not forget that a lot of these cases are benign. So
I think they will discuss everything in the panel. Dr. Sneha is the expert here. And I think, as you said, younger age, I have a mother and daughter who have recurrent fibroadenomas.
Fibroadenoma is always coming back with a bang.
So thank you
so much.
And thank you, Dr. Sneha. Special thanks to you for this opportunity. And I think two messages as a chairperson, as a future FOXY leader, I want to give to Dr. Sneha, that like we say that the ultrasound should be done by obstetric and gynecology, the ultrasound of breast is not that difficult, and we have a then and there diagnosis, especially when there is cystic mass or we went to aspirate the pus. So I think you take, and the second thing is very, very judicious use of hormone replacement therapy. So to future leader, as Dr. Sneha, I say two things that you advocate ultrasound, because I am doing a presented paper and this is not that very difficult also. So thank you, Sneha, and thank you all the organizer for this.
Thank you so much, Dr. Sneha and Dr. Usha Sharma ma'am, Mina Saman and Supriya. Thanks.
Thank you, madam. So we come to the end of this session. And I thank the speaker, Dr. Sheila Mane madam, and the chairpersons, Dr. Sadhana Gupta ma'am and Dr. Ranjana Khanna ma'am. So over to you, Charu.
Yes, thank you. So after this in-depth presentation by Sheila Mane madam, we now move on to our next session, which is taken up by two brilliant speakers, Dr. Charulata Bapai and Dr. Swasti. They are going to speak on nipple discharges and fertility preservation in gynecological cancers, respectively. And to chair the session, we have yet brilliant combo of two dynamic fervent leaders as chairpersons, Dr. Abharani Sinha and Dr. Mina Saman. To introduce Dr. Abharani Sinha, madam is professor and head of the department at SKMCH Muzaffarpur. She is the ICOG Governing Council member 2021-22 and was the past president of Patna Obstetric and Gynecological Society and also the chairperson of Quiz Committee FOXY in 2015 to 17. She's a national corresponding editor Jogi from 21 to 23 and has been a UG and PG training teacher with experience of more than 26 years and has contributed so many chapters and presented papers all over. She is the recipient of MS Signature Awardee 2021. I welcome you, Abha ma'am.
Thank you, Charu. Thank you.
Thank you, ma'am. Then we have our next chairperson, Dr. Mina Saman. Mina ma'am is Senior Consultant HOD Obs and Gynae at Kurji Holy Family Hospital, Patna. And she is a chairperson, Foxy Clinical Research Committee at present, and also the Secretary General Isoparb at present. She was the Vice President, Patna Obs and Gynae Society from 2019 to 20, and was the Secretary of Patna OBGYN Society also. She was the proud orator of Kamini Rao Oration in 2005.
Charu, you already introduced me. Thank you.
With these words, I welcome both our chairpersons and hand over the mic to them. Thank you so much.
Okay, good evening. At the outset, I'd like to thank Professor Usha Sharma Madam, President Isoparb, and Dr. Mina Saman for giving me the opportunity to participate in this webinar. And my special thanks to Dr. Sneha Buyar, Chairperson Study of Breast Committee, because I think she is doing a wonderful job. Because breast, I think, is a neglected subject. The students even don't like to read about it. But it is a very practical thing, and we all should know everything, right from the breast lump, nipple discharge, and all non-cyclical mastalgia, cyclical mastalgia. I think she'll be dealing all these in the panel discussion. But in this session, we are going to have a talk on nipple discharge. And this is going to be taken up by Dr. Charulata Bape. May I have her CV, please? We all know that nipple discharge, I think it is one of the very alarming signs. So we all should know that when we should be concerned about it, like if it is unilateral, bilateral, bloody, clear, or associated with pain. I think she's going to talk all about it. And may I have this opportunity to introduce her? She's a consultant gynecologist, endoscopic surgeon, and obstetrician from Pune. And she's director GEMS Hospital and Endoscopy Center. And she's doing a very good work as national coordinator in Foxy Breast Committee. I've met her many times in many of the webinars. She's an honorary consultant in Dinanath Mangeshkar, Oyster and Pearl Hospitals, Cloud9 Hospital. She has done training at Beams under Dr. Rakesh Sinha, lots of training in endoscopy. She has also won Best Video Award and presented many video and presentations at international and national conference. And she is Associate Professor at DS College of Physiotherapy and trustee at Bal Kalyan Sanstha and recipient of Dr. Smita Jog Award. And before calling her, I would also like to thank the two dynamic coordinators of today, Dr. Supriya Jaiswal and Dr. Charu Modi. And also would like to appeal for Dr. Supriya Jaiswal. She's going in for adolescent committee as chairperson from our society. So all of you please support her. With these words, I invite Dr. Charulata Bape to please come and present her talk on a nipple discharge. Dr. Mina, would you like to say some words?
Thank you.
I think after Dr. Charu's given her talk, I think.
Okay.
Thank you, Abhati.
Thank you so much for those kind words. And it is indeed my proud privilege to be speaking in a webinar of Isoparb. Thank you so much, Dr. Usha Sharma, Dr. Supriya Jaiswal, Dr. Charu Modi, Dr. Mina Saman, madam. And indeed, I'm so privileged to have as such intelligent chairpersons like Dr. Mina Saman, madam, and Abharani Sinha, ma'am. And also, it is such a difficult task for me to speak after a great orator and a great teacher like Sheila Mani, ma'am. I will be brief and to the point, considering the restriction of time. My talk today is on abnormal nipple discharge. The breast is indeed an organ of growing concern. The form, function, and pathology of the female breast are major concerns of medicine and society. As mammals, the breast nourishes the young. The breast contours occupy our attention. As obstetricians, we seek to sometimes enhance its function. Like when a young girl has delivered a baby and is unable to produce adequate milk, we want to enhance its function. While unfortunately, if some unfortunate girl loses a child, we need to diminish its function. Well, as gynecologists, the appearance of inappropriate discharge worries us as it could signify serious disease. Sheila Mani ma'am has already touched upon the anatomy of the breast. I will not be speaking much in detail about it. And we shall move ahead to the kinds of nipple discharge that we have. When the secretions from a non-lactating breast are abundant or persistent enough to discharge either spontaneously or with manipulation from the duct orifice, it is termed as a nipple discharge. It is indeed a cause of great anxiety both to the patient and the physician. The patient finds her obstetrician as her first point contact most of the times, and hence we need to be in-depth knowledgeable about the different kinds of nipple discharge, and hence we are here to discuss this. This discharge can be either physiological or pathological. It can be unilateral or bilateral. And how do we elicit this discharge? Well, the pressure must be applied to all sections of the breast, beginning at the base and working up towards the nipple. It is the third leading breast complaint with a prevalence of 5 to 10% among all women. And why are we so worried about it? Essentially because as many as 7 to 13% of these can be an indicator of a malignancy in the breast. What do our fact files suggest? The discharge is a true direct drainage from the mammary duct or the ducts which appear on the surface of the nipple. The nipple discharge in breast cancer usually implies tumor infiltration into the ductal system. In the olden days, in 1950s, all nipple discharges were needed to be subjected to mastectomies, essentially because there were no diagnostic modalities available at that time. Thankfully, because of recent advances in the diagnostic modalities, now we can have a much more radical approach to the treatment, and we can have so many duct conserving surgeries or breast conserving surgeries for this entire problem. We have a wonderful array of colors of discharges that can come out through the nipple. Most common of which is, of course, the milky discharge. When do we get a milky discharge? It could be a woman who has, delivered a baby up to 2 years back, and even for 2 years after that, she can have a milky discharge coming up. Pregnancy, we all know, pregnant girls can have a little bit of milky discharge starting very early in pregnancy also. Women on oral contraceptives can have a milky discharge. Inappropriate galactorrhea because of stress, prolonged suckling. Drugs, I think, friends, is a very important reason of milky discharge. Most importantly, which we see are the antiemetics. We have so many, young girls who are having so much of stress and acidity, and they are given domperidone. And it is this compound which can very frequently give rise to a milky discharge. So one of the first questions that we ask, young patients or any patient is if she has acidity and is taking domperidone, almost surely we can clinch the diagnosis. Danazol, antihypertensives can also cause milky discharge. Hypothyroidism, pituitary adenomas, hypothalamic lesions, herpes zoster, thoracotomy scars, bronchogenic carcinoma are also causes of milky discharge. Well, if the discharge is bloody or serosanguinous, our tentacles are going to go up because it can signify an intraductal papilloma, which has a high incidence of having a ductal carcinoma in situ. An intraductal carcinoma, sometimes even a duct ectasia or fibrocystic disease can come up with these kind of discharges. A clear or watery discharge could also be an indicator of a ductal cancer. A greenish or a yellowish discharge is usually because of ductal ectasia, which we're going to discuss later on. Purulent discharge, infective, retroareolar abscess, and in our country, tuberculosis can never be forgotten. A serous or a sticky discharge could be an indicator of a fibrocystic disease. So these are the various kinds of nipple discharges that we can have, and so the color is very important. Friends, we need to distinguish whether the discharge is from the duct or whether it is from the surface of the nipple. Paget's disease, eczema, and chancres could be responsible for discharges from the surface. So now whenever we have a patient coming to us with abnormal nipple discharge, what all are we going to ask her? Obviously, a detailed history regarding any duration of amenorrhea, whether there is any a pregnancy status that we are dealing with, whether the discharge is unilateral or bilateral, since how long is the discharge, what is the color of the discharge, any medications she's taking, any trauma, whether she's on oral contraceptives or any kind of HRT that she's on, any history of previous breast cancers or ovarian cancers is very important. Now, we distinguish the findings into two kinds, the red flag findings and the non-red flag findings. Which are the red flag findings? If the discharge is unilateral or uniductal, if it is bloody or if it is serous, if it occurs spontaneously, if it is persistent. Most importantly, friends, if there are associated skin or nipple changes like inversion of the nipple, which has just been dealt with, or if there is a lump present, then our tentacles are going to go up, and we know it is a red flag finding that we are dealing with. On the other hand, what would be a no red flag situation? If the discharge is bilateral, if the discharge is milky, if it is non-bloody, if it is multiductal, then we know that probably it is not malignancy, although we always have to rule out malignancy. We do a pregnancy test wherever indicated, a QAC test to rule out blood in the particular discharge. Tests like thyroid levels, prolactin levels for hyperprolactinemia. This is out of the context of today's talk, so we will not be dealing with it. And the treatment is going to be cause specific. How do we look after a case of a red flag case of nipple discharge? Again, the triple assessment algorithm. The more we hear about it, the more we realize how important it is. The clinical assessment, the radiology, and the histology. I think no clinician can ever forget these 3 points as far as assessing any problem with the breast is concerned. So what all can we do? The clinical assessment we talked about, radiology, ultrasonography, mammography are obviously the mainstay. Histology, we do not think too much about FNAC these days. It is the core needle biopsy, which is very, very important. Is there any role of nipple discharge cytology? Well, it is a reasonably specific method in the diagnosis of malignant and suspicious cases, but maybe somewhat less specific for other diagnoses. If the findings suggest malignancy, that is, we have a hard irregular lump, or we have, our radiological features are suggestive of malignancy, we are definitely going to refer her to an onco surgeon for a multidisciplinary approach for further management, whether it is a lumpectomy, whether it is a modified radical mastectomy. Obviously, the onco surgeon and the entire team will be deciding. Now, if there is no lump present, then what are we going to do? She's come back with a report saying that there is no lump present anywhere. What are we going to think of? It usually can be an intraductal papilloma, ductal ectasia, but still we continue to think of malignancy. And how are we going to differentiate? Undoubtedly by radiology, which is ultrasound, mammography, ductography, MRI, and ductoscopy. There are a number of papers available which tell us about the importance of the various imaging methods in cases of nipple discharge. Mammography, they say, has a low sensitivity in cases of nipple discharge because the lesions are usually small, retroareolar, and intraductal. It can show calcifications which are mainly associated with papillomas and duct ectasias. But we realize that ultrasound is extremely important in all cases of nipple discharge with high-frequency transducers. Detection of ductal carcinoma in situ or invasive carcinoma via ultrasound has a slightly higher specificity and sensitivity even as compared to mammography also. A Doppler ultrasound can differentiate an intraductal nodule from sludge by showing vascularization. What about MRI? Do we really need to do an MRI in each and every case of a red flag case of nipple discharge? Well, the European Society of Breast Cancer does not validate it in all cases of abnormal nipple discharge. It can be performed in patients with suspicious nipple discharge and a normal ultrasound and a normal mammogram. Non-mass enhancement is better with MRI. Now, what about galactography? What exactly it is? It was the gold standard for assessment of nipple discharge for a long time, but now is slowly being replaced by MRI because MRI has a slightly higher sensitivity than galactography. But because of the high cost and poor availability of MRI, even the galactography even today stands the test of time. And so we're going to just talk a little about galactography. What is galactography? Here we cannulate the duct and you inject a radio-opaque dye into one or more ducts, and a mammogram is performed without sedation or anesthesia. So that means it is an outpatient procedure, something similar to what we do as far as HSG is concerned to check the fallopian tubes, where you have a dye being pushed in and having a good quality X-ray. It has a sensitivity of 76% and a specificity of 11%. Filling defects can be seen in intraductal papillomas, irregular masses or multiple intraluminal filling defects, and dilated cystic structures in duct ectasias can be seen. So as we discussed, most of the times you see a filling defect or dilatation, you can see an abnormal cutoff, and some cases, of course, are reported normal. But filling defects can be seen beautifully on galactographs, which can guide us further. Most of these filling defects are papillomas, sometimes duct ectasias, and sometimes carcinomas in situ when they undergo histopathology. In summary, the nipple ductogram is a useful diagnostic tool to identify and localize the cause of nipple discharge. The localization ensures a high probability of removing the etiology of the discharge. Localization also offers the possibility of a focal duct excision, which preserves greater sensation and function, avoids nipple inversion, and decreases the likelihood of seroma formation. What do you mean by ductoscopy? Well, ductoscopy is looking inside the duct of a breast. With the advent of this particular procedure, which is a microendoscopic procedure, it is possible to visualize the abnormalities in the ductal system. It is done in many major cities, major hospitals. Bombay does it, Pune has it. I'm not very sure about whether it is done everywhere, but the main advantage of this is that tissue can be retrieved for histopathology, and consequently a patient with nipple discharge is prevented from having to undergo an invasive and fairly blindly executed surgery. It can be performed as an office procedure or under anesthesia. So these are the various diagnostic modalities that we can undergo, and we can decide what exactly is the diagnosis that we have reached. We just need to touch a little. We know that malignancy is going to be talked about, many other things are going to be talked about, but conditions like duct tactusia, duct papillomas are less touched upon, and hence we're going to be speaking about it in this particular talk. What is duct tactusia? It is a condition wherein a milk duct beneath the nipple widens, the duct wall thickens, and the duct fills with fluid. The discharge originates from multiple ducts and is usually bilateral. It is a disorder of the perimenopausal or the menopausal age, and imagine a woman of that age having a strange kind of discharge, which is greenish black or sometimes cheesy. She's definitely going to get worried about it, essentially because it can also cause nipple retraction and nipple inversion, friends. And so we need to be wary about whether we're dealing with malignancy or whether it is simple duct ectasia. You are going to feel a subareolar mass also in this particular condition. And how are you going to diagnose it? With the help of ultrasound first and maybe ductography also. Malignancy always needs to be excluded. Sometimes duct ectasia can get infected and so needs to be treated with antibiotics. Excision of the mass may be warranted. It can, of course, be left alone because it is a self-limiting condition. What about an intraductal papilloma? It is a benign tumor found in the breast duct, but it has a high risk of being associated with atypia, ductal carcinoma in situ, and frank malignancy. It may be central or peripheral, may be single or multiple, and presents with a bloody or a clear nipple discharge. Sometimes the papilloma may be palpable as a lump. It can be diagnosed on ultrasound, galactography, or MRI. A core needle biopsy is definitely going to be advised. If you have a ductoscopy, that will be really great. And the treatment involves surgical excision in the form of lumpectomy because of the possibility of malignancy. Of course, if you can excise a single duct by microdocectomy, that will also be fantastic. So this is a small algorithm for the management of patients with nipple discharge. If you have systemic causes, you're going to manage it accordingly. You're going to evaluate diagnostic evaluations. If it is unilateral, spontaneous, from a single or multiple duct, without a suspicious lesion, send the duct excision or single duct for patients with significant nipple discharge from multiple ducts, and for patients with nipple discharge from a single duct also. If you have a suspicious lesion, an excisional biopsy is indicated, and management will be whether it is a malignant case or a non-malignant case. With that,
sorry to interrupt, ma'am.
Yes, this is my last slide.
Yeah, thank you so much.
Nipple discharge, though physiological in most cases, may warrant underlying malignancy in 7 to 13% of cases. Red flag cases, including those with unilateral, single duct, bloody or clear discharge, with or without a lump, have to be taken seriously. Galactography, ultrasound, and MRI play a key role in the diagnosis. Treatment depends on the underlying problem. Ductoscopy has largely benefited the evaluation and treatment of abnormal nipple discharge. Microdocectomy is the surgical excision of a single duct in women with nipple discharge who wish to later breastfeed in the absence of malignancy. The breast is an integral part of a woman, and hence every gynecologist must be well versed with managing breast diseases. Thank you so much for this opportunity, and thank you for the patient hearing. Thank you very much.
Thank you, Dr. Charu, for your wonderful deliberation on nipple discharge. You have touched all the points, and especially the red flag signs. I think all of us need to remember those signs and try to differentiate between physiological and pathological causes of nipple discharge. And of course, the triple approach as Dr. Sheila Mane has already said, and you have also emphasized on it, like going step by step, like clinical examination, then radiology, and then that imaging, and that should be followed by histology. I think if one just goes systematically by these three approaches, I think one is able to diagnose the condition and then treat it. So thank you so much. Dr. Mina, please.
Yeah. Yeah, thank you, Dr. Charulata. You've so clearly, systematically highlighted the various lesions, which are the red flag ones, which are rather benign, and highlighting also on the ductactasia and the papillomas, which are less talked about, less frequently talked about. We know cancer is going to be dealt with by Dr. Swasti. Then you've also highlighted, like MRI, we have to be judicious in what investigations we are ordering. MRI, though it sounds quite fancy, it may not be appropriate, it may not be available, and even simpler ones like ductography has its own place in the diagnosis workup of these patients with discharge. And the color, the associated features, they all, how they go on to, coming to a diagnosis. And I think when a patient walks up to us in our clinic and she's concerned, just, the reassurance, she's almost in her mind, she has already made a diagnosis of cancer. And when we tell her, no, it may not be that, it's such a huge relief for her. And she's actually, when she enters with the results of whether it's an ultrasound or a mammogram, the X-ray ones, so that fear psychosis is there. I think over the years, the breast thing has come up. So because we are talking more about it through advocacies like yours, Dr. Sneha and all, patients are now more open and coming up. That's why maybe we get a lot of patients with all kinds of breast problems coming to us. Thank you. And if there are any questions there, we can have them after the next talk, maybe.
Thank you so much, madam. Thank you for those kind words. And the I can see what the mind knows. And so only when the mind knows these things, we can approach our patients much better, because otherwise we got on a back foot, because we ourselves are a little unsure about what this discharge is exactly. So thank you for taking up this topic, and thank you for inviting me here. Thank you so much.
Can we have the CV slide of Dr. Swasti? So it's indeed a pleasure to, introduce Dr. Swasti, who's senior consultant, a gynae oncologist. And she's also like she's also been trained in endoscopy and also robotics. And what I really liked about her CV was also this. She's involved actively in increasing the awareness of women towards cancers, rich academic, clinical, surgical, and research background with numerous papers and presentations in the national and international conferences, and editorial member of many international. Of course, we know she's a gynae oncologist par excellence, associated with many reputed hospitals like we have the Max Cancer Center, then the Galaxy Cancer Institute, Pushpanjali Crossley Hospital, specialist in Ahalya Hospital, Abu Dhabi, UAE, editor, so on and so forth. So, so ethics and audits also go as a areas of interest. So that's really interesting, and I think we'll have we can have more of you in some of our more other this thing with your varied, interests and specialization. So over to Dr. Swasti.
Thank you so much, ma'am, for your kind words. And at the outset, I would like to thank Isoparb and the Foxy Breast Committee, especially Dr. Sneha Bhuhar, ma'am, for having me here and giving me this opportunity. I hope my slides are visible.
Yes.
So today I'm going to talk to you about fertility preservation in gynecological cancers. This is something which is very close to my heart, and we're seeing more and more of young women with cancers, not only gynecological, but also breast cancers. And it's very relevant to address these issues at the initiation of the discussion for further treatment. this should be a part of discussion. And every woman dreams of motherhood, and we all know that. And even a woman with cancer does dream of motherhood, even despite of the fact that she may have to delay motherhood for a while. So I'm going to talk to you about three major gynecological cancers. We'll talk about ovarian cancer first, followed by cervical and then endometrial cancer. And to discuss ovarian cancer, I'll demonstrate a case, and I'll discuss this, which we managed with the Onco Fertility team. And this is about a 27-year-old unmarried sexually active woman who underwent a right laparoscopic ovarian cystectomy somewhere outside in 2012, which was reported as a borderline serous ovarian tumor with no angiolymphatic invasion, and the cyst fluid was negative for malignant cells. It was reviewed elsewhere, and this was reported as a borderline papillary serous tumor, right ovary with possible microinvasion. She followed up 6-monthly ultrasounds for the next 3 years on her own. She's a medical professional, so she didn't see anybody but kept on doing regular 6-monthly ultrasounds. And CA-125 or any other tumor marker was not done preoperatively, but post-operatively somebody suggested. So she did a CA-125, which always was reported as normal. Now, after 2016 September, she stopped following, and then suddenly she experienced slight pain. And in February 2020, she was seen by a senior gynecologist who referred to me with her imaging findings. And clinically, she had a 7 to 8 centimeters mass arising from the left side of the pelvis. So this is something which we found on her transvaginal ultrasound. This is a solid cystic ovarian lesion with neovascularization, and subsequently an MRI was performed, which revealed a 5 centimeter lesion and some eccentric debris on anterior and lateral sides. Tumor markers were all normal, a CA-125, AFP, beta, HCG, LDH, and an HE4. And then 6 months later, an MRI was done. And, after doing this MRI, she was referred. So when she came, I did another MRI on her, to which the size of the lesion had increased from 5 centimeters to about 8 centimeters. There were mural nodules within the lesion and some papillary projections with no extracystic extension. So this was just an MRI pelvis initially. So a CT upper abdomen was planned, and which was unremarkable. And again, we saw some soft tissue components in the right adnexal mass and some liver cysts. So previous history of borderline right ovarian serous tumor, post-ovarian cystectomy, again, the same side lesion. The questions are we dealing with cancer? She's young, unmarried. What about her fertility? She was sexually active, so I could examine and do. So there's a very fine line of discussion, debate, and judgment when you look at fertility and survival. And once you discuss all this in entirety with the woman, and if she's too young, maybe with her parents, or if she's already having a partner, with the couple, and then decide and discuss about the pros and cons of, addressing fertility issues during or after treatment. This case was managed slightly differently. Usually we advocate that once you deal with the ovarian tumor, you should then look at fertility preservation. Now, who should deal with this problem is a pertinent question. So usually it's a team approach. It's a multidisciplinary management. And we do have an Onco Fertility clinic at one of our centers at Max Noida, where we have an infertility specialist, a medical and a surgical and a gynae oncologist on board. And they discuss all the cases with the primary OBGYN and the other referral community to initiate treatment as well as fertility preservation in a joint manner. And this is a branch which has come up in a big way, and this is known as Onco Fertility. So once you take the right steps, you can just sit back and relax. And very important for an ovarian cancer is to understand what is presumably going to be or likely going to be the stage at which you're dealing with, because unless and until it's a stage 1A, you should not attempt or aim at fertility preservation. So suppose this woman had presented with ascites, which was positive for malignant cells, or there was, capsule involvement or surface disease, which upstages disease to 1C, you would not want to do fertility preservation at that stage. So any ovarian tumor with a 1A stage, where the tumor is limited to one ovary, capsule is intact, and this holds true for fallopian tube lesions or primary peritoneum as well. The moment you have a iatrogenic or a surgical spill, or you have a capsule rupture or surface disease prior to taking the patient for surgery, all this upstages disease to 1C1, 1C2 and beyond. And these patients are then not qualified for a fertility preserving procedure. So in this situation, we had in-depth, she had multiple doctors in the family, we had detailed discussion. And I told them that, look, if this disease is, we were not sure looking at the MRI whether the disease was involving the surface actually or not. So I told them, if the disease involves the surface, I will not be able to conserve her other ovary. And then they said, why don't you stimulate her prior to taking her, for the surgery. And after a lot of debate and discussion, we sort of deviated and individualized from the conventional protocol. And we took her for an ovarian stimulation and a oocyte cryopreservation prior to the surgical procedure. And that was the onset of COVID, and that was done in full blown first wave. So if you look at a prognosis of ovarian cancer, any early ovarian cancer, the problem with ovarian cancer is most of the women are diagnosed in stage 3 and stage 4. So we lose our time and we lose that opportunity to actually offer fertility preservation. I'm sure after UK talks, we know that we cannot reduce mortality by doing a CA125 or a serial ultrasound. But of course, I think an annual gynecological examination definitely makes a lot of difference. And rather than an ovarian mass being detected at 12 centimeters with a situs or with a mental disease, it's definitely going to make a difference, and particularly in women where there is a relevant family history of ovarian or breast or colorectal malignancies, which are a little more associated. So an early stage detection definitely has a survival of about 95 to 97%, but the unfortunate bit is only 33% women are detected in early stage. So if you look at the indications of fertility preservation in ovarian cancer, if you're looking at a borderline ovarian lesion, one could offer in stage 1A, where you do a unilateral oophorectomy or a bilateral or a unilateral cystectomy, depending on the kind of lesion. If you're offering a cystectomy versus a oophorectomy, there's higher recurrence rate in fertility sparing procedures. There's no difference in mortality. If you're dealing with anything over 1C and a borderline, then also you can preserve fertility in certain situations, but with a comprehensive staging. So it's very important to understand, to image, to counsel, and to be able to tell them an algorithm or the plan, a surgical plan, and the possibilities prior to taking them up for a definitive surgical procedure. So in malignant germ cell tumors, of course, grade 1 and stage 1 disease, but germ cell tumors do well. So I would say that invasive epithelial tumors also in stage 1A, we can offer them fertility preservation protocols. In fertility preservation, we must understand 3 basic things. Number 1, that any fertility preserving procedure or initiative is a deviation from the standard treatment protocol. This must be made very clear to the family and to the woman, because if you are doing a fertility preserving procedure, it is only to buy time and to give that time to the woman to actually conceive and have a baby and then complete the standard treatment. That is very clear. Second thing is that whenever you are attempting a fertility preservation procedure, the risk of progression of malignancy at its normal rate cannot be denied. So that is something that we are not doing. So in any case, in any woman where she needs chemotherapy, and that may be gonadotoxic later, like we were dealing with the breast cancer discussion yesterday, I think even in ovarian cancer, the chemotherapy is actually very gonadotoxic. Now, if you're dealing with somebody who's got ovarian cancer and is likely to get chemotherapy, it will be definitely beyond the stage 1A. And when you're dealing with such kind of invasive epithelial ovarian cancer, then probably fertility preservation is not a good idea. But if there is a lot of crunch and there's a lot of critical issues involved, you could still do an oocyte cryopreservation in that intermittent period between surgery and chemotherapy, which has its own problems of actually access to the oocytes, of stimulation immediately in the post-op period, where there's pain, there is healing, and there's a lot of pelvic surgery already done. So with all this in background, just a little bit about how there's a natural decline in the fertility potential of a woman, right from the number of oocytes at birth till its reproductive years. And every woman has a genetically determined ovarian reserve. We are all aware of these things, and all cancer treatments, including chemotherapy, radiation, and hormonal treatments, would decrease the fertility potential or the ovarian reserve to subtle extents and progress them towards menopause. So ovaries are chemosensitive, and there is a loss of primordial and growing follicles with some radiation induced damage. Now in ovarian cancer, we are not using radiation therapy as any kind of primary or secondary treatment for ovarian cancer, but this holds true when you're dealing with cervical cancers or early endometrial cancers. So can we preserve fertility in this woman? Yes, there are various kinds of fertility preservation protocols. You could use pelvic radiation therapy and shielding from pelvic radiation. We will talk about transposition in cervical cancer. And when you're looking at a surgical way to protect, of course, as I said, fertility sparing surgery, you spare the contralateral ovary. Don't take a wedge biopsy. It looks grossly normal, and if there's no surface disease, because again, you will reduce the number of follicles of that normal ovary. And cryopreservation of oocytes and embryos and ovarian tissue is a potential treatment strategy. So what should be done, as I just mentioned about the techniques? Also, I will talk about these techniques in detail when we come to cervical and endometrial cancer. But of course, you can look at oocyte and embryo cryopreservation, ovarian tissue cryopreservation, and retransplantation, and in vitro oocyte maturation, primordial and pre-antral follicular cultures, and uterine transplantation. And we know our very own Dr. Puntambekar has initiated a lot of uterine transplantation. Now, the challenge lies whenever you're dealing with malignancy. Of course, there will be a lot of hormonal issues, and I think we need to venture more into this arena, and I'm sure a discussion with him would be very, very valid. So now also ovarian suppression or GnRH agonist, as you know, prior to initiation of chemotherapy could be one strategy, where there's a lot of controversy and current evidence says it doesn't really protect us. So doing a serum AMH at the outset would know what is the baseline ovarian reserve, because if you're having somebody at 31 or 32 coming with an ovarian tumor, we know marriages and childbirths are delayed with women working and having delayed marriages. So already they are at a compromised reserve, and having no partner at that time could lead to further challenges. What is the quality of oocytes? All that need to be studied, or if they are if there is a stable relationship, how stable it is likely to be, one doesn't know. And we discussed this yesterday, where Dr. Puneet talked about how people can fall out of relationships once cancer is diagnosed, and we do see it every day. So what should be the timing of fertility preservation? Ideally,
sorry for interruption, madam. Hope you know we have limitations of time.
Yeah, I'll take 2.5 minutes more.
Please. Thank you, ma'am.
So fertility preservation in ovarian tumor should be ideally after the surgery, and there are lots of concepts about counseling, as I said, cost and concerns, side effects, the inability of the woman and her family to decide straight away with so much jargon and so much information being given to them. So all this needs to be discussed in a gyne-oncology tumor board, and we do encourage our patients and their families to attend and understand all the viewpoints. Then I would also like to talk to you about this particular case. Of course, she underwent a cryopreservation of the oocytes after stimulation. And then when I did her surgery, she had bulky contralateral ovary, so bulky that I really was wondering, because see, most of the times we do surgery prior to oocyte cryopreservation, so we never get to see what is the impact on the other ovary. She continues to have this bulky ovary till date. She's under my follow-up. Grossly bulky, more than about 5 to 6 centimeters in size, but no lesion as such. I got an intraoperative ultrasound done to document that there was no lesion in that ovary, because I'm going to do a fertility preserving procedure and leave that ovary back behind and with a recurrent setting of a borderline serious microinvasive cancer. So I was worried on taking that decision. So this was also a new thing to me. And the frozen section again revealed a borderline serous tumor. Final report came out as microinvasive. We do have limitations and challenges in frozen section sensitivity. There is an importance of sending an intact specimen, so preferably use laparotomy as an approach and do not rupture or morcellate the tissue, and send them intact. So it came out as a micropapillary borderline PT1A-N0. All the complete staging was done. All the nodes, omentum, peritoneal biopsies was negative. And I'll skip up this borderline thing and I'll just quickly talk about cervical and endometrial cancer. The idea of the basic concept in these slides that was that most of the times when we are operating on borderline ovarian tumors, cystectomy has a higher recurrence. Pregnancy rates are good. Cystectomy versus oophorectomy. So if you have a larger lesion, consider doing an oophorectomy or unilateral oophorectomy, because borderline tumors grow at a rate of 1 centimeter a year approximately. So now a quick word on cervical and endometrial cancers. So cervical cancer, we have some criteria. The tumor size has to be less than 2.5 centimeters. It has to be FIGO 1A1 with LVSI or 1A2 with 1B1. It could be either squamous or adeno. Upper endocervical canal should not be involved as per colposcopy or MRI. No regional lymph nodes mets. And then you can transpose the ovaries, do a trachelectomy, and offer fertility preserving procedures like oocyte or embryo cryopreservation or ovarian cryopreservation, tissue cryopreservation. So this is in a nutshell about how we do a decision making for cervical cancer. Young woman wanting a fertility preservation, classify it into either FIGO 1B or 1B1 less than 2. If radiochemo is necessary, then just go in and do a laparoscopic transposition. And otherwise, if it's a 1B2 adenocarcinoma, or you go ahead with doing a radical hysterectomy, then there you can't preserve the fertility. Now, in earlier stages, you could do trachelectomy if no radiochemotherapy is needed. So trachelectomy won't go into detail. Very interesting endometrial cancer. I'll just tell you my own experiences into this. So complex atypical hyperplasias or early endometrial cancers where there is a well-differentiated adenocarcinoma. So the criteria is it has to be stage 1A. It should be confined to endometrium. Ideally, there should be no myometrial invasion. We generally look at the tumor grade, so it should be well differentiated. Tumor size should be small. Hormone receptor status should be done ideally. I've managed 3 successful pregnancies in endometrial cancer cases where they were PR positive. We need to know before giving them high doses of progesterones, because if you're using progesterones and doing serial hysteroscopy DNCs, you need to understand whether they're receptor positive or not. If they're not, they will not benefit. So there may be a subset of patients which may be ER positive or PR negative, and these are the ones which will be not favorable. So we have to optimally select these patients, do a MRI prior to this, and have a slide and block review if they've been reviewed outside. So what do I usually use? I give them megestrol, because medroxyprogesterone 100 mg per day is very difficult in India. We don't have those potential things. We do get them in 10 milligram things. So I usually use megestrol acetate 160 milligram a day. And we give them continuously without a break for 3 months, do a hysteroscopy and a biopsy 3 months later, wait for the atypical or malignant changes to resolve. Such three monthly, 3 hysteroscopies, total of 9 months we wait. If the atypia or malignancy changes revert back, we straight away direct them for an IVF. And the problem with this is there's a lot of calcification happening at the endometrium once atypical changes resolve. So the issue arises of endometrial receptivity, but fortunately all my patients conceived in the first cycle of IVF and they are blessed with healthy babies. So if at 9 months this doesn't resolve, one has to resort to radical surgery. In that we could conserve the ovaries also and subject them to oocyte tissue, oocyte cryopreservation or an embryo cryopreservation later, depending on how things are. So that's about it from my side for all these 3 major cancers. Take-home messages are just one simple thing. All those women with cancer, if they are detected early, they can have a potential opportunity to become a mother, and they should not be denied of motherhood. Thank you so much for your patient hearing. I'll be happy to answer questions.
Thank you, Dr. Swasti. I think indeed it was a very informative talk. And as you rightly said that all young women who are suffering from malignancy, if they come in early stage, early grade of the disease, we should give them an opportunity for childbearing. But of course, the cases have to be chosen very, very carefully. We have to look at the stage of the disease, the grade of the disease, and of course, the treatment has to be offered in the form of ovarian cancer. If it is I think in germ cell tumors, it gives the best results if we do an unilateral oophorectomy. And the other important message that you said that we should not bisect the other ovary. If it looks healthy at the time of laparotomy or laparoscopy, we should leave it as such because that will further cause loss of follicles and the patient will have difficulty to conceive. I think that was a very important and a very good message. The other point that you said that the stimulation post-treatment, I think the stimulation is also very important. And oocyte freezing, embryo freezing, I think that is the call of the day. We hear so many such cases. But the most important point is to have a very careful follow-up of these cases, because these cases, they can progress, because we all know that these borderline cases, even in a small biopsy, we can miss them. It may be, if we send a complete sample, that may be an invasive or a micro-invasive disease. So it is very important that we should have a proper histological evaluation and proper follow-up of these cases. Now, coming to cervical cancer, again, only up to stage 1B1, we can, and if the tumor mass is less than 2 centimeters, we can offer them fertility preservation surgery. And trachelectomy, I think few gyne-oncologists are doing it. But again, here also we need to have a proper follow-up. And of course, cerclage, I think that should also be given. If the patient, she conceives, I think a cerclage, a cerclage should also be given so that pregnancy is retained. And our follow-up is again important. And before chemotherapy, we can do ovarian transposition, as you rightly mentioned, and then we can stimulate the ovaries and retrieve the ova and go for IVF. And for endometrial cancer, again, progesterone therapy is the answer, especially for atypical hyperplasia. I think we have been using this LNG-IUS in few young patients, but of course, follow-up, as you said, rightly said, 3-monthly hysteroscopy, and the patient should be allowed to conceive once the changes, they come to normal. So I think it was a very, very enlightening talk, and I think all of us must have benefited by that. Mina, please.
Yeah, thank you. That was indeed a very good talk and thought-provoking also, that every time a diagnosis of cancer comes, it's not that we just, like Dr. Rishi said, that it's not just about saving the life, mortality. We are thinking beyond that, the quality of life and the desires of the patient to fertility. And of course, that you have covered. Also, I would just like to put in a word that even when fertility is not an issue, ovarian conservation as such also improves the quality of life for the woman. So if possible, we should think about it for the woman. So thank you. It was a great.
Thank you, ma'am.
Thank you so much. With this, we come to the end of this very captivating sessions dealt by Dr. Charulata Bapai and Dr. Swasti, wonderfully moderated by both our chairpersons, Dr. Abharani Sinha and Dr. Mina Saman. Thank you all so much. Over to you, Dr. Supriya Jaiswal.
Thank you, Charu. So we are over with the 2 sessions. Now we start with the panel discussion. To moderate this panel, we have Dr. Sneha Bhuiyar, madam, the main person behind the show. So again, let me see the CV. Yeah, Sneha ma'am, just let me tell a little bit about you. Like, madam, actually, she is the Managing Director of Sukanta Hospital, Yavatmal, with 29 years of experience, teaching experience of 5 years in VN GMC at Yavatmal. She has got lots of awards and credits like National Individual Award by Foxy, Anandi Bhai Joshi Award, Foxy President Appreciation Award, Foxy President Appreciation Award for exemplary work in cancer, in public awareness, then Champion of Foxy 2019 International MS Signature Award for phenomenal leadership, Lokmat Healthcare Excellence Award, Asia for GCC Award, and many more. So an official post, and actually she is at present a chairperson breast committee of Foxy, and she is doing great work in that. We continuously have been seeing her, and I would also like to say she's omnipresent, very active, very dedicated in her subject. And then she has been she is the governing council member of ICOG, founder president with the Vidarbha Isoparb 2017, president YOGS, then president clinical secretary YOGS, then executive committee member, organizing chairman of certificate Kriti Care or Nagpur, zonal AMOGS, breast cancer.
Thank you, dear Supriya. Thank you so much.
Ma'am. So over to you, ma'am, for the
yeah. Thank you so much. Once again, thank you, Isoparb, for this opportunity and excellent talks by all the speakers, Dr. Sheila Mane, Dr. Charu, and Dr. Swasti. And I'm going ahead with the panel discussion. I think somebody can help me with the CVs. I will introduce the panelists.
Kindly show the CV. Yeah.
Yeah. I'll be very brief with the panel discussion. We won't go into the theoretical discussion as we have had wonderful talks. We have the first panelist, Dr. Rita Kumar Jha, who is the Associate Professor of WIMS Pavapuri, President Isoparb Partner Chapter 2019-21, Executive Member of Isoparb. So welcome, Dr. Rita Jha. Next. Yeah. We have Dr. Amita Sinha. Next, at present, she's the consultant gynecologist from Patna, and she was Vice President Isoparb Patna chapter. She is at present, and she is a member executive committee of POGS and Isoparb. Welcome, Dr. Amita. Next, please. Yeah, so Dr. Charu Modi, she is a breast committee member, and yes, very active, vibrant. At present, she's holding the post of chairperson adolescent committee of Patna Society and chairperson public awareness committee in 1920. Welcome, Dr. Charu Modi.
Thank you,
next, please. Yeah, Dr. Manisha Gate, again, a very vibrant and active member of breast committee from Chandrapur, and she's the West Zone coordinator of Food and Drug Surgical Equipment Committee, chairperson Women's Doctors Wing, IMA Chandrapur. She was the secretary of Chandrapur Obsgynae Society, Maharashtra, and I welcome her. Welcome, Dr. Manisha. Next, please. Dr. Rashmika, again, our own breast committee member. Very active, vibrant member of breast committee. She was organizing secretary of the AMOGS, that is a state chapter of Maharashtra, and she was a secretary of Amravati Obsgynae Society in 1920. Now she is the joint secretary of Vidarbha Isoparb. Welcome, Dr. Rashmi.
Thank you.
So with this brief introduction, Abhishek, please stop sharing. Yeah. So I share my screen, and without much ado, I go with the panel discussion straight away. I welcome you, all the panelists, once again. And as you all know, that breast is a symbol of womanhood and ultimate fertility, and both as a result of disease or surgery, it can evoke the fear of mutilation and loss of femininity. And that's the very reason we all are here to discuss the breast concerns. And with this, I straightway go to the case discussion. Dr. Rita Jha. Dr. Rita, today my voice is not well, so I'm not going to speak much. Please, straightway send this patient to you. She's a 20-year-old girl complaining of painless lump in the right breast since few months. And when you examine, you find a lump which is round, well circumscribed, 2 by 2 centimeter and firm in consistency. It is non-tender, freely mobile, not attached to the skin or underlying structure. There are no axillary lymph nodes as well. What do you feel is the diagnosis of this patient, and how do you investigate? Do you really need to investigate? How will you manage her?
Yeah. First of all, sincere thanks to entire National Isoparb team, especially Dr. Usha Sharma Di, Dr. Mina Saman, and a special thanks to Dr. Sneha for considering my name to be a panelist in this academic fest. Thanks a lot. And going to this case, this young girl having a lump which is well circumscribed, firm in consistency, non-tender, freely mobile, and not adherent to skin or underlying structure. And you just mentioned there is no lymph node palpable in that girl. So probable diagnosis is fibroadenoma. And as we generally pronounce this tumor as mouse in the breast. And this young girl, though this is we all know this is a benign neoplasm, but in recent years, there has been a change in its diagnosis, I think I can say. So does it need further evaluation? But a palpable mass in this young girl can cause anxiety, both to the girl and her parents or the entire family. So in this case, we should do evaluation. Besides clinical evaluation, we should go for ultrasound for this girl, and ultrasound, in my opinion, is sufficient for evaluating this mass. Because we don't know this is, and further investigations, I don't feel that at this younger age and after 30 years of age, any other investigation is required in this particular case. And
very good. So we definitely agree with you, Dr. Rita, and we want to give this message that there is no need for further investigation of tissue diagnosis, and we have to. So how will you manage this case? Whether you would like to go ahead with surgery or how?
No. Before going to the exact treatment for this young girl, I just want to mention what changes has become come in recent years in the principle of management of this fibroadenoma. Previously, we all know this fibroadenoma is a benign neoplasm, and particularly we were considering it for removal, excisional biopsy, and all because of the fear of malignancy. But in recent years, it has been seen that it is not a neoplastic lesion, and it arises. It is a epithelial and stromal component. It is a biphagic tumor, and it is a hyperplastic
dysplasia rather than neoplasm, because it arises from entire lobe and not from a single cell, which is so specific for the development of a neoplasm. So currently, these are considered as hyperplastic, and it is developed during the period of menstrual age under the influence of estrogen and progesterone. And
yes, so very rightly mentioned, madam, that yes, it is a stromal and epithelial proliferation of the terminal duct lobular unit. Our concern is, should we really remove it, or rather, which fibroadenomas should we excise?
No. So in this particular case, I don't think SC needs any surgical removal. And as this is a hyperplastic lesion and not a neoplastic lesion, we can surgical exclusion to exclude malignancy is not necessarily required in this particular young girl, and up to, in my opinion, up to 30 years of age. And we will only go for other investigation and other modality of treatment if she is having increase in size of the tumor, or if she is having any symptom related to it, or if that lump rapidly grows, and if she is having any risk factor related to that, so that we can think of another management.
Very true. To summarize, we have, for this case, definitely we do not need surgical management or excision because the lump size is very small. The NICE guidelines say that if the size is more than 5 centimeter, then we should go ahead with excision. For this patient, particularly, if the size is more than 5 centimeter, then only we should go ahead with excision. But in some cases, if the patient is too anxious, if the fibroadenoma is causing discomfort to the patient, and it's causing some cosmetic problems which she is worried about, even after counseling, if they persist on the excision, then you may have to go for excision.
Or if she is having any risk factor because of a strong family history, or if she is having any benign breast lesion prior to this, and if she is having a obesity problem, her BMI is more than normal, then only we can consider other investigations and followed by line of management other than
yes. So fibroadenomas more than 5 centimeter in dimensions, fibroadenomas persisting after 35 years of age, fibroadenomas which are called as giant fibroadenomas, and complex fibroadenomas where they are harboring epithelial calcifications, apocrine metaplasia, sclerosing adenosis. These are the only fibroadenomas, and especially if the lady has family history of breast cancer, then only we should plan for excision of such small fibroadenomas at such a younger age. Thank you so much, Dr. Rita. So now we now move on to the second case, and Dr. Amita, this is a case for you. Yes. You have a 35-year-old woman who complains of pain in both the breasts, and she is really worried about her painful breast. Both the breasts, especially, the pain increases typically before every menstrual cycle, menstruation rather. And when you examine, she tells you that it's a painful lump. When you examine, you find both the breasts are tender, and you find the rice grain nodularity, little thickening on the upper and outer quadrant on one side, but then you don't find any lump. What is your diagnosis? Does it really need any further investigation? And what is the treatment for this patient?
Good evening, everyone. Thank you, Dr. Sneha, for including me here as a panelist. Now coming to the case. As the case is on examination, both breasts are tender, but no well-defined lump is found, though the patient is complaining of breast lump before the menses. But according to our examination finding and rice grain nodularity, slight thickening at the upper and outer quadrant, my provisional diagnosis goes to fibrocystic changes in the breast. Because fibrocystic changes in the breast are very common, particularly in this age group of women, and all the signs and symptoms are suggestive of fibrocystic changes. Her breast pain is mainly cyclical, which comes before the menses. It's bilateral, And on the examination, we find the rice grain nodularity on the upper and outer quadrant. So if we know that breast pain is a rare symptom of breast cancer, but women who present with breast pain, but where we until we diagnose the condition by further investigation, we can't assure her. So definitely in this type of case, I would like to investigate her further. But first, number one cause is her age has crossed 30 years. She is approaching 35 years. And secondly, evaluation of breast pain is very important to determine whether the pain is due to normal physiological changes related to normal fluctuation, or is it pathological, such as breast cancer. Earlier there was a consensus that there is no chance of breast cancer in fibrocystic changes of the breast, but now it's reported that its incidence is increasing up to 3%. So there may be hidden case of cancer. So we must investigate this type of case. And second, one more thing I would like to say, that this patient is 35 years age, and so for only assurance after physical examination is not enough. So we should investigate her through ultrasonography, and guideline says that up from 30 to 39 years age, we can also offer her both ultrasonography and mammography. But ultrasonography is sufficient for diagnosis in this type of case. If we find any negative finding in the case, then we can assure her regarding her absence of cancer. But sometimes what happens, after listening the low risk of cancer, patient did not turn up for the follow-up. So it's better to counsel her.
Dr. Amita, your patient is asking you, what is the cause? Why this has happened? Do you advise me anything to, any dietary modification, any lifestyle modification?
Yes. Because after examining, if there is no palpable mass, no skin changes, no bloody nipple discharge, I will assure her that there is no cancer. And I will explain her that though it is not malignant, but you need some modification in diet. We have primary line of treatment. So because your pain is diffuse, we will explain her to take less caffeine, because there are something that caffeine intake increases the incidence of fibrocystic breast. We will take restricted fat intake of diet, increase fiber intake, more fruits or vegetables, and primary treatment for this type of case is support to the bra, physical support or hot fermentation. I will also ask her if she is taking any OC contraceptive pill for contraception. I would ask her to stop all these things. So these are the basic thing regarding her dietary modification, reduction of tea, coffee, and reduction of.
Yes, she has two concerns, pain and lump. How do you tackle those?
Yeah. Because regarding pain, at first I will give her supportive treatment, just I told earlier, support to the bra and hot fermentation. But if it is not removed by these things, then I will give her either local or oral NSAID. And apart from oral or NSAID, things are not going to relieve, then I will go for second line of treatment. First, most of the cases removed cures with this NSAID and removal of that modification. But if she does not become confident and her pain continues after this initial treatment, then we go for either tamoxifen or danazol, because both these drugs have many side effects. So we take care for, we wait for 6 months after giving this initial treatment of either NSAID, a physical support, or a stop hormonal therapy and right modification. But if she does not feel comfortable and she feels lump, then first duty is, we can assure after giving her ultrasonography report, after physical examination, that there is no lump. Don't worry for that. We will follow you regularly by these investigations. But for pain, you will have to take these medications. So I will follow this patient like this. Tamoxifen or danazol. Tamoxifen, we can give 10 milligram orally once daily for 1 month at least. Similarly, danazol can be given 200 milligrams once
I think,
daily.
Dr. Amita, we don't give these drugs very frequently or commonly.
No, not very frequently. After 6 months, waiting for 6 months, if she does not improve by giving primary treatment, then these are the second line treatment. These are not primary treatment.
Yes.
So
very well done.
try to do
Yes.
this.
Yes. Yes. So very well answered, Dr. Amita. Just to summarize, I would say this is a problem, or these are the complaints which are hormone related. So we have to just explain them that this is because of the imbalance of the estrogen and progesterone hormone, and that is why you are getting it just before menses. And for that, maybe you must have noticed that it worsens with caffeine and premenstrually, and so we have to reduce your intake on caffeine and sugar and improve on your fiber intake. And of course, for the pain part of it, hot fomentation, local support, local or systemic analgesics, all that may be necessary. But yes, sometimes I'm sure all of you have used vitamin E, gamma-linolic acid, and all these evening primrose, all this, masala preparations. But it's not, we can't say it empirical. It has definitely worked and helped our patients. But if at all they don't respond to this, yes, raloxifene, SCRMs, these are the drugs which are, or meloxifenes. These are the drugs which are very, very helpful and giving very promising results. All of us are using it, I think, over last 3 to 5 years, and we're getting very good results. Tamoxifen and danazol, I don't think, if at all the patient has very, very incapacitating pain in some situation, maybe very rarely you may need to use this drug. So what we have to just assure here is try and rule out malignancy, because in this case, the patient is worried about malignancy. So once you are sure that, ultrasound is suggestive of normal hormonal changes, and they can be, multiple fluid-filled spaces, small one, but sometimes they may be having even a larger cyst like this. So it can be, giving her a throbbing pain. If it is a asymptomatic cyst, we need not remove, but if it is causing pain, incapacitating pain, sometimes you may need to aspirate this simple cyst and send it for cytology, of course. So that is how we have to tackle this situation. So thank you so much, Dr. Amita, once again. So we come to the next case now, Dr. Charu Modi.
Yes, ma'am.
Yeah, Charu?
Yes, ma'am.
This is case for you. And yes, right from her delivery, we're going to take you through this case. You have this patient, delivered 5 days back. She comes to you with fever, which is overfilled, tight breast like this. When you examine, you find she's, having tense, tender breast. You are trying to squeeze the nipple. There's no milk flowing through this. What do you feel the diagnosis is, and what has led to this condition, Charu?
Yes, ma'am. First of all, thank you so much, ma'am, for the wonderful opportunity given to me. And at the same time, I would like to thank the National Isoparb team as well. Now, coming to this question, ma'am, as she is para 1, who has delivered 5 days back, we presume that she might be relatively inexperienced. Probably in these times, also in Corona times, because of lack of communication with the healthcare workers, or maybe lack of communication with family members due to bonding problems and all, she might not be able to feed the baby correctly, as nobody must have told her about proper latch-on techniques, different positions also. So there occurs stagnation of milk in the breast because of inadequate emptying and improper latch-on and techniques, and inadequate breast emptying, leading to engorgement of breast, stagnation of milk, ultimately leading to engorgement.
Any relation to initiation of milk, Charu?
Yes, ma'am. Ideally,
initiation of breastfeeding.
Yes, ma'am. it has got a very direct relationship with the engorgement, because ideally breast feeding should be initiated as soon as possible. It is often said that whenever in normal deliveries or during cesarean section also, whenever the baby comes out, and we should let the baby we should let the baby be on the mother's abdomen, so that the baby crawls on its own to the female's breast or the mother's breast. So we should advise initiation of breastfeeding as soon as possible, preferably soon after delivery. So it has got a very great impact on engorgement per se.
Very good. That's a great message, Dr. Charu. In fact, even the Government of India initiative, Mother's Absolute Affection, they train the paramedics saying that, the baby should be delivered to the mother's abdomen and let the baby crawl, as you have rightly pointed out, and let the baby latch on its own to the breast and start feeding on its own. And this is the most successful formula, if at all everybody does that. So, very good message you have conveyed. So, suppose now this patient has got breast engorgement. She didn't get a good counselor like you, Charu. She didn't get a good support from her healthcare provider, and now she has landed up into this problem, and she comes to you. Now she already has engorgement. How would you advise her?
Yes, ma'am. First of all, we would like to counsel the mother and reassure her that this is a temporary phase. With continued effort, she will be relieved of it. So we have to advise the lady to continue to breastfeeding, because breast suckling is in natural way, it's a very good pump, or a breast pump, I should say. So we should teach her proper latch-on techniques, different positions, and if at all she is still not able to feed due to either maternal conditions like inverted nipple or flat nipple, or there is any condition with the baby like galactosemia or that cleft problems, so we should advise her that it can be relieved on its own if you continue to breastfeed the child. And if at all she is not able to get relief by suckling, then we can advise her to go in for hot and cold compression. Hot compression ideally should be managed, or should be advised 10 to 15 minutes prior to feeding, because it releases the tense up breast, and it allows the proper flow of milk from the breast. And after feeding, we should advise her for cold compression in the form of silicone gels, cold silicone gels, or the cabbage leaves. If at all this also fails, then we can always go in for pumps. Either she can do manual pumping of the breast by expressing milk in a clean pot, or certain pumps are available which are manual or battery operated, like as you are showing, ma'am. It can be electric pumps also.
Suppose, Charu, our gynecologist, they're telling you the patient is just not allowing you to, pump it out, manual expression. So how do you counsel the lady, and how do you manage the manual expression?
Ma'am, ideally, hot compression should be advised to her either with a hot towel, which is,
that should reduce her pain and the edema part of it.
Yes, ma'am.
And then when you counsel her that I'll be at most gentle with you, and this is the only treatment that's going to relieve of your engorgement, so she will be more cooperative. Right.
Yes, definitely.
Okay, so what are the various positions you can tell for the...
Yes, ma'am.
Yeah.
Different
Abhishek,
positions.
please mute everyone. Abhishek, please mute rest. Yeah.
Yeah, ma'am.
Ma'am, most common positions are cradle hold position, in which the general mass feeds the baby. There are different positions.
I think you need to mute yourself, Abhishek. There's noise from your side. Yeah. Thank you.
There can be different positions like cross cradle hold, then kangaroo position, or the side lying positions. We have to teach these antenatal patients right from the antenatal period, so that they learn and they come to know of different various other options also of feeding the baby. Plus, we have to tell them about the latch-on techniques also. The proper latch-on should be that the areola should, nipple should be in the mouth with some part of the areola, and the chin, nose, and umbilicus of the baby should be lying in a straight line as compared to the head. And the baby should suck vigorously to the breast so that the milk flows easily.
Yes. So it has to be a very effective breastfeeding with good latch, and it has to be a frequent and complete emptying of the breast. Okay.
Yes,
and then hot fomentation before starting feeding, and cold compresses at the end of the feeding.
Yes,
Charu, suppose this patient has not reached to you in time, you know, she didn't come to you and, you know, she tried to manage it at home. And now she comes to you with high-grade fever with chills and engorged both the breast, and you know, she tells you that there is a huge lump in the left breast. And when you examine, you find that there is a lump of almost 6 by 6 centimeter, tender, hot, fluctuant swelling. What is your diagnosis and how will you manage now?
Ma'am, with these findings, I think the diagnosis is popping out itself. It might be a case of breast abscess. Untreated engorgement can lead to mastitis, which further can lead to breast abscess. So this abscess is quite big, 6 by 6 centimeter side, but the first line of treatment is still reassurance to the mother, because they get very panicked with such a
No, Charu, we don't agree with you. Abscess anywhere, pus anywhere in the body has to be drained out. There's no rule of reassurance.
Yes, ma'am, coming to that. We have to tell her.
So which way you have to do that?
Yes, ma'am. First of all, after the basic investigations like CBC and all, this abscess can be managed by 2 ways. Earlier, the line of management was surgical treatment in the form of incision and drainage with packing of the breast, which was very troublesome and very painful to the patient. Now, new options are available, such as in draining aspiration of the pus from a wide bore needles of around 14, 16, 18 gauge needle. With it has got various advantages, like it avoids the need of surgery, avoids the anesthetic hazards, and minimal hospital OPD stays there. Patient need not be admitted in the ward for this operation. And moreover, she can breastfeed the baby from the affected side also.
That's the most important message we want to give, because if at all, like what you said previously, we used to send the patient to surgeon, and incision and drainage was the only way of management. And the patient used to have a huge, you know, open wound and daily dressing, packings, and it was such a messy, painful thing to handle as well. So she used to have painful dressings daily, so she used to not breastfeed the baby. At the same time, you know, problem with the mother and problem with the baby. So now, whether the breast abscess is small or big, if it is a smaller abscess, you can drain it at single setting. If it is a larger one, may need multiple settings, but you have to try and go ahead with the multiple aspiration or needle aspiration. Even if the abscess is deep-seated, you can go for the ultrasound guided aspiration, needle aspiration. Yes. So this is what the data says. These are multiple studies. This is a Cochrane database saying that there are many studies, but around 300 to 500 cases. And they are saying that they are getting equally good results with both the ways. But as obstetrician, you know, as doctors, what we are trying to promote breastfeeding, protect breastfeeding, we have to share all the responsibilities, because breastfeeding is not only beneficial to the mother, baby, and the family, but to entire nation. And it's not only beneficial, but if not breastfed, the baby can have serious problems. And that's the very reason our prime aim should be to promote and, you know, protect breastfeeding. And that's why even if it is a breast abscess, we have to go for needle aspiration as a conservative management. So thank you so much. Charu, very well contributed. These are the various slides for breast cancer, but I'm going to skip this because because of lack of time, we are going to the case discussion directly. Only one slide I want to project here, that how you have to teach the paramedics or your patient for the self breast examination, and how you have to train yourself for this clinical breast examination, that you have to inspect the patient, expose the patient properly first with both the hands by the side and raised above the head and then on the waist. This is for the patient. She has to expose herself in front of the mirror and watch for various abnormalities, which we are going to discuss it later on. Then after inspection, she has to lie down, or maybe even in standing position, she can palpate with her palm of the hand, upside down, side to side, round to concentric or radial, and not to miss any part of the breast. And she can notify any abnormalities. That is for the patient self breast examination. And same thing when you do without using any gadget, that is clinical breast examination. And what are the abnormalities? All of you know this. So just to see that whether the breasts are symmetrical, equal in size, whether there is any abnormality in the shape, whether there is any lump or dimple change, discoloration in the skin, nipple retraction, any axillary mass on palpation, maybe nipple discharge. So all these things has been already discussed in the talk, so I'm going to skip it. Only now we go straight away to Dr. Manisha. Manisha, this is a case for you. Hello, is Manisha there?
Yes, ma'am. Yes.
Yes, Manisha.
I'm rightly here.
Yes, yes. So this is a case for you. 32-year-old Nullipara. She notices a small lump in left breast. She says it is painless. When you examine, there is a vague lump in left breast, 2 by 2 centimeter, non-tender, hard in consistency, but not fixed to the skin or underlying structure. There is no nipple discharge and axillary node. Right breast is absolutely normal. What is your probable diagnosis, Manisha, and how would you go ahead with the management?
Yes. First of all, I would like to thank the Isoparb Society, respected Dr. Usha Sharma Madam, Dr. Mina Saman Madam, and our own Sneha Buyar Madam, and all the organizers for giving me this opportunity to be the part of this academic feast. Madam, she is a 32-year-old nulliparous with a vague lump, which is having an irregular outline, non-tender and hard in consistency, but without nipple discharge, and also no axillary nodes palpable. And the opposite breast is normal. So mostly the diagnosis is pointing toward the malignancy of the breast. Yes. After doing the physical and the local examination, along with the lump, along with the axillary examination, first of all, we will investigate this patient thoroughly for the confirmation of our diagnosis. The main, we will go for a mammosonogram, mammography, it can be done, but the diagnosis is always to be confirmed with FNSC or a true cut biopsy. Again, the role of MRI in this patient is only when the above tests are inconclusive, or also if we have to define the stages of this disease and to plan the treatment accordingly. Then regarding the options of the treatment,
yes,
the surgery, we are having
young lady,
surgery.
What is the stage of this disease? Do you feel, how do you categorize? Early or advanced malignancy?
No, she is in early stage as her skin is not involved, and also she is not having any axillary lymph node involvement. So there are surgical options for her, like she can go for radical surgery or conservative surgery, which is prevailing along with this time, and which is always more of a time after deciding the staging. After
what
we
is
have,
your opinion, whether you
yes.
will go for radical surgery or conservative surgery?
Madam, as she is a nulliparous and of young age, we can go for a conservative surgery.
Yes,
for
how
this
do you
patient.
justify that? How do you justify?
Actually, she is having she's in the stage, early stage of cancer.
Yes, agreed. She's young, she's nulliparous.
Young patient is there, and she is nulliparous. So we have to be very patient in such patient. We have to be doing the workout properly, and also reassurance, because she's a young and nulliparous. She must be concerned about her further.
Correct. Your counseling should be such that, you know, even for this case, at this stage of the disease, whether it is radical or conservative surgery, the 5-year survival rate or the long-term outcome is same. And this has been proven beyond doubt. Okay, 10 years, 20 years down the line, we used to have only radical surgery for breast cancer. At the moment of breast cancer is diagnosed, it was radical mastectomy or MRM. But over last few years, there is an option of conservative surgery with radiotherapy, because they have comparable results. Okay, go ahead.
Yes, ma'am. And then we have to send the specimen for the histopathology and HER2 studies along with the ER and PR. Then also the planning of chemotherapy and radiotherapy are done according to the histopathological report. And after planning the proper chemotherapy and radiotherapy, the patient is to be subjected for the same. Yes, ma'am.
So, Manisha, your patient is saying that, okay, now we go for conservative surgery, but I don't want to lose my breast and the cosmesis.
Yes, ma'am. She can be offered oncoplasty, that is the conservative surgery for breast cancer, with the help of oncosurgeon, and plastic surgery with the cosmetic outcome is the fundamental goal with this cosmetic result in this patient. But long-term studies have proved that they are having similar recovery result in both of this. But again, this has to be followed by chemotherapy in most of the cases.
Okay, so I'm sorry, you have managed this patient, you have done her oncoplasty. Now, regarding future plan, how do you advise her whether she can conceive? If no, what contraception she can use?
Yes, again, we will advise her to wait for a few years for conception. We will generally give her progesterone this contraceptive like LNG or progesterone only pills can be prescribed to her for the period of her getting well, and then planning for
how much? 2 years
minimum,
from
2
the
years,
completion of treatment.
Yes.
Right. That is the message we have to give. Very well done, Manisha.
Thank you.
Now we come to the last case. Dr. Rashmi, this is for you.
Yes.
25-year-old Paravan who, delivered just 2 months back, and she comes to you with painful right breast. You find she tells you that there is a swelling, breast is red, swollen, and you examine her, you find red, swollen, tender, edematous breast. The skin is like, powder orange appearance. Nipple is retracted. There's no localized lump, but she's, constantly she's telling you that there is an insect bite like itchy. She gives you history that, so yes, it is since last 8 to 10 days and I'm not getting relief. Dr. Rashmi, what is your diagnosis? Differential, I would say once again, and how would you go ahead with the management? What is the commonest diagnosis?
Thank you so much, my dearest Neha madam, for including me. Madam, this is a very particular and peculiar type of malignant breast malignancy. And this my first differential diagnosis would be inflammatory carcinoma of the breast. Why this is such a particular case? Because a patient who is PNC, 25 years old, delivered 2 months back with no lump in breast and typical warm, red, swollen, tender, edematous breast with pudgy orange appearance. We would many of the time we might just confuse the condition with breast abscess.
Mastitis.
Yes, mastitis. Actually, I want to say mastitis.
Correct.
So, ma'am, I have seen a patient in the periphery. She was treated for mastitis for quite a long duration, and because it was not getting resolved, when she came to the higher center, and we sent her histopathology examination, and then it turned out to be inflammatory breast carcinoma. Why this type of carcinoma is so particular? Because the age of the patient is usually younger. Then another thing, that there is no palpable lump in this type of carcinoma. Third thing is that because it mimics exactly with mastitis. Moreover, because of the young age, the density of the tissue is high, and because of the high density, even the ultrasonography or the mammography, and there is absence of lump, so the exact diagnosis could not be made. So what happens, that this is a very aggressive type of malignancy. Though this is a rare type of malignancy, but the 5-year survival rate is very less. So what happens, that once we identify the patient, she's already in stage 3. Why? Because skin is already involved. Even more late, if we go, that will be directly stage 4. It could be primary type, which is arising primarily in breast, or it could be a secondary type, like it has been treated and then again arising. So this is a very highly aggressive, though rare, but it has a very poor prognosis.
True, Rashmi.
Yes, ma'am.
Happening at such a younger age, being so aggressive, and already in stage 3 or 4 at diagnosis, the worst possible combination the malignancy presents with. And that is why, rather than playing with the patient, one antibiotics and the next antibiotics, one doctor and the next doctor, I think we have to go to the further investigations and confirmative diagnosis with tissue diagnosis, because this is a malignancy where you don't have lump, so mammography will not catch this. So biopsy is the only answer to this malignancy, and that's why we should straightway go for tissue diagnosis, make the diagnosis fast, send the tissue for hormones, ER/PR status, send it for HER2 and immunohistochemistry, and then you immediately start managing. For this malignancy, there is no role of conservative surgery.
Yes,
absolutely. It has to be a radical surgery, and then of course the post-operative chemotherapy, Herceptin, whatever.
Yes.
So, Rashmi, very well described and discussed. Thank you so much. Thank you all my panelists. Only once again, as press committee chairperson, I have always urged you and all the Foxians that every obstetrician and gynecologist has the window of opportunity. The women come to us for whatever their problems. Make it a habit to examine their breast, try to find any abnormality. If you find any abnormality, you subject them to further investigations. If you don't find any abnormality, you teach them self-breast examination, guide them about their risk factors, whether they have family history, medical history, which makes them susceptible to breast cancer. You guide them for their time-to-time appropriate screening procedures, and you save their lives. Early detection saves lives, friends. So we are the saviors. I want all of you to take this mission ahead. Thank you so much, National Isoparb. Thank you, Madam Usha Sharma, Dr. Mina Saman. Thank you, all my respected senior faculties here. And thank you, all my panelists. Wonderful participation. Thank you so much.
Thank you, ma'am.
On behalf of all the panelists.
Thank you from our side. Thanks a lot.
Madam. Yes.
Thank you, Sneha madam, for on the behalf of all panelists, I congratulate you for a wonderful program and best conduction of panel, ma'am.
Thank you so much. Can I see Usha madam here? Do I see Dr. Mina Samant or Usha madam? I would like to have some comments from you.
Dr. Mina Saman is here.
Mina ma'am is there.
So I think in a very limited time, you've done justice. You've covered all varieties of cases and highlighted all the important aspects. And I think very clear and crisp messages that each panelist has given regarding the cases. That was a fantastic panel discussion. Of course, what to say of the previous three talks, all of them were just super. So Dr. Sneha, big congratulations for you. You've chalked out today's program and you've done full justice to it.
Thank you so much, dear Mina. Thank you so much. Thank you all the faculties. Thank you, Chief Guest, Dr. Rishikesh Pai, and thank you, Dr. MC Patel, sir. I think sir is still there. Yeah. So if we have some comments, we can have it. I think over to you, Supriya. Thank you.
Abha ma'am is there.
Abhadi will give her some comment.
Very well conducted panel, Sneha. Congratulations. You always do it very well. And I think you are doing a great job making people aware of the breast. Like, we should make it a habit to examine each and every, whenever we are examining any patient, we should make it a habit to examine the breast. Then only we can detect these cases early and we can manage them. And it should be an evidence-based management. That is very, very important. So the more and more webinars you're doing with different societies, I think people will now start looking breast at a different way and will be managing it in a better way. So thank you. Thank you, Sneha.
Thank you so much, dear madam.
So we come to the end of this program today. And I take the privilege to thank everyone to propose the vote of thanks. First of all, I would like to thank Sneha madam, first of all, because you have been the main convener of this program, the mastermind, or whatever you can say. You have chalked out in a very less time, and although you were sick and very busy in spite of that. Then I would like to thank our president, Dr. Usha Sharma madam. She never says no. And same here with Dr. Mina Saman. She also said, ki kar lo, like it is okay. Although we had another one program. So she also agreed to chair. Thank you, Meena Di. I would like to thank our chief guest, Dr. Rishikesh Pai sir. He was also very much engrossed in Fusion conference, but then still he came and gave a overview of everything. Then Dr. MC Patel sir, he is also very cooperative. Always he comes whenever he is committed. He is a real committed person. Thank you, sir. Thank you for being here as a guest of honor. Then I would like to thank the speakers, Dr. Sheila Mane, Dr. Charulata Bapai, and Dr. Swasti. So all three talks were wonderful. And to chair the session, we had real brilliant people, Dr. Sadhna Gupta, Dr. Ranjana Khanna ma'am, Abha Rani Sinha, Abhadi, very well known to us, very dear to us, Dr. Mina Saman. So all of them chaired the session so well and made it so vibrant. Then the panel discussion. Madam, you always do really take the panel so well. So I thank the moderator, Dr. Sneha ma'am, and then the panelist. I really thank Dr. Rita Jha, madam. She also had real problem, but still she could manage, and she's another dedicated and very hardworking. Rita Di, thank you very much.
Thank you, Supriya. Because of you only I participated in this panel.
I kept on persisting.
Yeah. Thank you, Dr. Rita.
Many works to do in these few days. But I took this opportunity and I enjoyed it a lot. All talks and panel. Dr. Sneha, it was a wonderful panel. And I'm so impressed with your deliberation and with your panel.
Thank you so much. Thank you, everyone.
Then Dr. Amita Sinha, she's also a very hardcore Isoparbian right from the beginning. She had taken the Patna Isoparb so well. And so she also participated. And thank you, Amita Di, for accepting in one call itself. Then Dr. Charu, madam, she's the member of your breast committee and a very dedicated person. Everybody knows her for her hard work and commitments. then Dr. Manisha Ghate and Rashmi Kahar. Both of you, thank you very much for joining. And we had been talking in between before the programs and for the CVs and everything. We had good interactions. Thank you everyone, and thank you all the viewers. And last but not the least, the Corona Remedies they really did good job. They're showing all the CVs and the technical support. Thank you very much for everything. Thank you, ma'am.
Thank you so much, ma'am.
Thank you. Thank you so
Yes,
much.
thank you, Abhishek.
Thank you so much, ma'am.
Thank you, Corona Remedies.
Thank you.
Thank you. So you can end the meeting, isn't it, ma'am?
Yes. Chalo. Bye-bye.
Thank you so much.
Bye-bye.
Thank you.